उनका पावर नहीं आ रहा है, तो कह रहे यूपीएस 10-15 मिनट से चल रहा है, तो कभी भी बंद हो जाएगा।
एक और शीट अच्छा ये आ गया।
ऑडियो तो चल रहा है, वो ऑडियो चल रहा है। वो कह रहे हैं कि पीछे से लाइट नहीं आ रही, कभी भी बंद हो जाएगी बीच में। तो स्टार्ट कर लेते हैं, जहाँ पे बंद होगी वहाँ रोक देंगे, है ना? हाँ, जितनी देर चल रहा है उतनी देर चला लेते हैं। ठीक है, स्टार्ट।
Video duration is 6 minutes and discussion wrapped within 1 minute. But is the time go to reflect? Yeah, 6 minutes at 10 minutes. It's written in the book. I hope it's 6 minutes is the video presentation. 6 minutes.
आप ऐसा करते हैं, शुरू कराओ आप, बंद होगा तो फिर से करा लेंगे, क्या फर्क पड़ता है? हाँ, और फिर से बुलवा लेंगे, ऐसी कौन सी बात है?
ऑडियो चलना, ऑडियो ऑन कर देना है।
टाइमर 6 मिनट्स ऑन कर दीजिए।
A 66-year male who had undergone multiple intravitreal injections of Avastin presented with persistent submacular hemorrhage. 27-gauge vitrectomy was done without base excision. Internal limiting membrane was peeled using ICG dye. .40-gauge microcannula was used to inject TPA into subretinal space. TPA is used in the concentration of 12.5 micrograms in 0.1 ml solution. TPA is injected till it covers whole of the submacular hemorrhage and reaches beyond the temporal arcades. Fluid-air exchange is done so that air replaces about 60% of the fluid in vitreous cavity. Air is then exchanged with SF6 gas. Visual acuity improved to 6/36 after 2 weeks and to 6/24 after 4 weeks of surgery. The most common complication seen with this procedure is a macular blowout resulting in a macular hole. This is mainly due to the uncontrolled forceful injection by the assistant who is pushing the plunger while the surgeon holds the syringe. This also leads to shaking of surgeon's hand while injection. To overcome this, an automated subretinal injector can be made in the OR. A 1 ml tuberculin syringe is cut at 0.5 ml mark. Plunger is cut with a length of 0.1 ml longer than syringe. A small hole is made into the rubber of a 10 ml syringe. The cut tuberculin syringe is then fitted into the rubber. A hole is then drilled in the 10 ml syringe and its hub is removed. Tuberculin syringe prepared earlier is then fitted in this 10 ml syringe as shown. This apparatus is then connected to the VFI system on vitrectomy machine. The drug is filled into the syringe from top and microcannula is connected. The speed of the injection can be foot controlled. A 42-year female presented with macroaneurysm, pre-retinal, sub-ILM and subretinal hemorrhage. 27-gauge vitrectomy was done without base excision. PVT was induced with the help of triamcinolone. Vitrectomy was completed. ILM peeling was done using ICG dye and the sub-ILM blood was washed away. A 40-gauge microcannula connected to the subretinal injector was used to inject TPA in subretinal space. Notice the smooth injection and less shaking of hands in this case. Fluid air exchange is done so that air replaces about 60% of the fluid in vitreous cavity. Air is then exchanged with SF6 gas. The visual acuity improved to 6/12 at 4 weeks post-op. These are a few more cases of submacular hemorrhage treated with the same technique. Let's see if the subretinal injection of TPA is a viable option for large submacular hemorrhage or a retinectomy with drainage is needed. 85-year male, presented with complaints of sudden decrease of vision for 10 days. He was diagnosed as massive subretinal hemorrhage secondary to IPCV. Incidentally, he had undergone retinal surgery for vitreous hemorrhage, retinal detachment and subretinal hemorrhage in other eye too about 3 months ago. We plan to do vitrectomy with subretinal injection of TPA in this eye. After completing vitrectomy without base excision, ICG-assisted ILM peeling was done. TPA in the dose of 25 micrograms in 0.1 ml was injected subretinal using a 41 gauge micro cannula. Subretinal bleb was raised slowly with the help of a self-made subretinal fluid injector. The injection was done at 2 different sites. Fluid air exchange was done. 20% SF6 gas was used as tamponade. Patient was advised prone positioning post-operatively. 3 weeks post-op, significant reduction in subretinal hemorrhage was seen. 6 weeks post-op, subretinal hemorrhage had resolved and visual acuity improved to 6/9.
Excellent, Sangeet. I think it takes away the problems associated with injecting by self.
Yeah.
It's machine assisted. And I think the basic problem of taking a 1cc syringe, you circumvent it because when you adapt it to the silicone injector, you need an adapter which has got a piston which fits into that adapter, and the 10cc does the trick.
Yes.
So it works very well.
Yeah.
Good morning, everyone. I'll be presenting a video on combined tractional.
The web. A 10-year-old boy with diminution of vision in the left eye for last 1 month following a blunt trauma. There was history of aniridia and congenital glaucoma already on maximum medical therapy. The vision in the left eye was as low as 1/60 with no perception of light in the right eye. The slit lamp showed a subluxated cataractous lens with a CD-year-old boy with diminution of vision. I present spinning the web. A 10-year-old boy with diminution of vision in the left eye for last 1 month. I present spinning the web. A 10-year-old boy with diminution of vision in the left eye for last 1 month following a blunt trauma. There was history of aniridia and congenital glaucoma already on maximum medical therapy. The vision in the left eye was as low as 1/60 with no perception of light in the right eye. The slit lamp showed a subluxated cataractus lens with a CD ratio of 0.7 and a total rhegmatogenous retinal detachment was noted with early PVR and minimal vitreous hemorrhage. My apprehensions in managing this young boy were how I could avoid an IOP spike after the VR surgery to protect the cornea and thereby avoid silicone oil from coming into the anterior chamber. So taking a clue on how a spider spins the web, this is a template which is created and it goes from in to outside. We present the silicone oil retention sutures in this patient. A pars plana lensectomy was done, and this was followed by injection of triamcinolone, followed by the induction of the posterior vitreous detachment. Gently the detachment was taken to the periphery, and a limited amount of perfluorocarbon liquid was then injected on the posterior pole. The induction of PVD was further induced. A peripheral indentation was done to complete the vitrectomy, and a base excision was done. More membrane peeling was done to remove the membranes of the PVR. Perfluorocarbon liquid helped in providing a counter traction. More perfluorocarbon liquid was then injected. A 26 gauge needle was then passed through the limbus with a 10O proline suture from the opposite side, and through a railroad technique the needle was taken out. The same was then repeated again from the opposite side. And the needle was again taken out. The suture was then tied, and this helped us in getting 2 sutures in place. The knot was buried, and the suture was snipped off. The same procedure was then followed, perpendicular to the previous sutures. And a web of sutures was then spun. Again, the suture was tied and the knot was buried. We appreciate the entire web created of 10O proline suture, which helped in creating a barrier between the posterior and the anterior segment. This was followed by a fluid air exchange. Perfluorocarbon liquid was removed, followed by laser photocoagulation and silicone oil injection. At the end of the surgery, we left an air bubble which was anterior to the web of the sutures created. This helped to keep the silicone oil posteriorly without allowing it to come in the anterior chamber. This was the first post-operative day this young child was able to see from a close distance, where he happily picked up the 20D lens in the clinic. Post-operative follow-up, the child underwent a silicone oil removal and gained a vision of 660/36. The cornea was crystal clear and the retina was well attached, and this made the child ambulatory again. Thank you.
Dr. Manisha, that was fantastic. When did you remove the suture?
The sutures are still there. We really don't need to remove the sutures. The main purpose is that since this child was one-eyed, I was not sure when I would be able to remove the silicone oil. So
Okay.
the patient was aniridic, and you didn't want the silicone oil to cause any kind of corneal decompensation. So the child has undergone silicone oil removal, but the sutures are still there.
Okay. Can we think for a plan for a aniridic IOL with 4 mm central clear cylinder?
The main purpose of this surgery was to make the child ambulatory,
Yeah.
and he already has a very bad history of glaucoma.
Okay.
And we
Okay.
know that aniridic SFIs can create a problem with pigmentary glaucoma. So that's why I thought, let me just be happy with this.
That was fantastic.
In fact, Manisha, we had a similar case where we actually went ahead and put the aniridic IOL, and after the aniridic IOL, the cornea decompensated. So I would advise you not to put
Yeah,
in this
that's
thing.
right.
And one thing we noticed was when you do such a procedure of retention sutures and you make the patient
Next we have Dr. Shivani. Shivani is here. नहीं, शिवानी होता है।
भिजवाया था।
I do think they have the videos you had uploaded.
No? You'll have to load it again. I'll have to load it. Then I think I'll come back. I'll just check.
If you have it in your laptop, you can present from the laptop as well.
HDMI है उसमें. So, yeah.
I will request other presenters, Ruchika, please upload your video. Shitu, you uploaded? Please. It's better you upload so that it will take less time. Otherwise, वो shift करना ये करना it will take a lot of time.
So,
Rohan had come and had gone back, I think. Nikki Gupta, I can't see her. Nisha has done it. Ravinder? Yes, sir. Vaibhav? Yes, sir. Okay.
good morning, everyone. Just a short disclaimer about this video. There's a character that we have created in this video to explain how to deal with subluxated and dislocated IOLs and back complexes. This is a series of 4 cases that we have managed. So this entire video was conceptualized and created by Dr. Kumar and myself. And there is a character in this video which is not an animated character which it would look like, but it is actually me wearing a costume. So we've created handmade costume, and the suit that I'm wearing does not have any air vent or opening or eyes to see. So it was completely done blind by us. So I just wanted to say that, so that we wanted to introduce the character to add a fun element for it to be a nice teaching video and some pearls to take home to manage difficult cases, so that at the end of it we come out with a good outcome for the patient. So I'll just start the video. A subluxated back complex with an endocapsular ring. Patient gives a very interesting history that when he sits he cannot see, but when he lies down he can. So we decided it is possible to refix this back complex, created 2 Hoffman pockets on both sides. Once that is done, we decided to fixate the same point equidistant from the optic-haptic junction on both sides and do a railroad technique. The first pass is from below the endocapsular ring and the haptic, and the second pass is from above the endocapsular ring and haptic. Then both strings are brought out and tightened. Once that is done, a similar technique is employed for the opposite side. Equidistant points are selected and railroaded. The first pass will go below the optic-haptic junction and the endocapsular ring, and the second pass goes from above. One can now see how beautifully this whole back complex easily centers on the visual axis. We can achieve good centration by refixing the same back complex which had actually subluxated. There is a dislocated IOL. There is no sticker from the patient. B-scan obviously showed an IOL, but the design is unknown. What are our options? Explant the IOL, glue a new IOL, or do a posterior iris fixation. We started doing vitrectomy, and to our luck and surprise, the lens started floating up. With a micrograsping forceps, we make sure that we grasp the lens and don't let it fall back and get it back in the anterior chamber. Interesting to note here is that these are non-foldable 6.5mm optic IOLs with dialing holes. Notice the orientation of the haptic. The plan was to glue this IOL, but in this orientation it cannot be glued. The only way out is to flip the IOL in the anterior chamber to get the orientation and angulation of the haptic correct. These lenses have a 10-degree forward angulation, so it is important to orient them in the right plane. One can see that through 2 0.75mm incisions, we have now flipped the IOL in the anterior chamber, got the orientation correct. We have already made 2 scleral flaps on 2 sides so that we can externalize these haptics. This is a non-foldable 3-piece IOL with stiff haptics. So one has to be very careful in externalizing these rigid haptics because they can break when we are trying to externalize them. After externalizing the rigid haptics from the scleral tunnel, the next step of course is to tuck this IOL and glue it. We tuck the IOL under the scleral flap with a 26 gauge needle, and finally we glue the original dislocated IOL in position. So through 2 0.75mm side ports, the original IOL could be refitted and well centered. In case of subluxated back complex, principles to follow are: to refix the back complex, point of fixation should be equidistant between both optic-haptic junctions to successfully refix the back complex. For dislocated IOLs, anterior vitrectomy is done to free the IOL. Orientation and angulation of haptics is corrected by flipping the IOL. Refit the original 3-piece IOL. Thus, complex cases have good visual outcomes when handled with care. Thank you.
Both the techniques were good actually, and nice outcome. Thank you.
Sir. Thank you so much.
Next presenter, Dr. Ruchika Patnaik.
सिग्नल है क्या नाम है 29 ना ये
That was really very nicely managed, Ruchika, I must say that. But I was just wondering why after the first brave flash when there was...
it was just, I just found the space not adequate to do a visco dissection, so I was just being a bit greedy and pushing the edge and tried to extend the incision. This was one of my initial cases and landed up perforating right in the beginning. So that made the manual dissection all the more challenging because the air just kept escaping.
Yeah.
And despite the repeated collapse of the AC, managed to still have a decent outcome, and the specular was also good even after a year.
Yeah, sometimes you have to leave a little bit of stroma over it in order to maintain the closure of the...
Yes, and just when I thought everything was going fine, I perforated once again. So I had 2 perforations in this. Yeah.
Thank you.
Okay, thank you, sir.
Next we have Dr. Shritu.
Incision, lenticle extraction or smile is generally considered a safe procedure with a low incidence of intraoperative complication. After docking the cornea, the femtosecond laser then proceeds to create a lenticule cut, a side cut, then a cap cut, and finally the incision to remove the lenticule. Using the point dissector, anterior and the posterior plane is identified. Following this, a blunt dissector is used to first separate the anterior plane, followed by the posterior plane. With sweeping motion, the lenticule is completely separated and then extracted using specially designed forceps. But sometimes things don't go as planned. Of all the smile complications, let's discuss a few. Suction loss can occur in case of eye movements, wet corneal surface, improper cone selection, and wrong head position. Scenario: we will demonstrate a suction loss during the posterior lenticle cut, which can be simply managed by converting it into a flap-based procedure. Suction loss at cap cut usually happens once the fixation light is blurred for the patient and the patient tries to search for it and leads to eye movement. This can be simply managed by redocking and making sure that the cone is centered. So how to manage the suction loss? If the posterior lenticle cut is less than 10%, then you can restart the procedure. But if it is more than 10%, then convert to LASIK. And if it is at the anterior lenticle cut, then repeat docking. Black spots occurs because of debris present between the patient's interface and corneal surface, dry cornea, or excessive use of topical anesthetic drugs, and can lead to difficult tissue separation, damage to the stromal bed, and delayed recovery. In this video, we see several dark spots which leads to lots of resistance during dissection done by blunt tip dissector due to uncut areas. But it is not very confluent and large and does not cause much difficulty and can be managed in a usual way. In case of very large and confluent area of black spots, it is better not to attempt any dissection or convert into LASIK. So how to manage a dark spot? If it is small, then continue in usual manner, but in case of large and confluent black spots, abort or convert to LASIK. Retained lenticule can present as a nightmare for even a most experienced surgeon. So what are the risk factors for retained lenticule? Factors for retained lenticule is irregular astigmatism, a thin lenticule, incorrect identification of lenticular planes, opaque bubble layer or black spots, improper technique of dissection. Intraoperatively, black spots was observed during laser firing. On dissection with the blunt tip dissector, we faced persistent resistance at 5 o'clock position with sudden loss of resistance at other sites, which brought the surgeon to suspect of retained pit. So the lenticule was examined to ensure any loss of its part. It is imperative to examine all the lenticules after removing them from corneal stroma to ensure that there is no bit which is retained. Here we noticed missing lenticule, so pocket exploration was carried out, but the retained bit was not located, which was then located on slit lamp examination easily, so we used the forceps and pulled out the retained bit. So to prevent the retained lenticule, we must completely separate the lenticule from both the surfaces and the side cut. ensure optimal corneal surface moisture, clean contact glass, and a thorough slit lamp examination at the end of the surgery. So if you can't find the lenticule in 10 minutes, postpone the surgery by 4 to 12 weeks, reassess with topo, ESOCT and clinical photo, and do the exploration by an experienced surgeon or topo guided PR. Last but not the least, a buttonhole cap due to wrong plane of dissection, which can be caused by sudden eye movement or improper dissection technique, and thin lenticule. The dissection has to be carried out carefully and is managed by using the forceps to localize the anterior plane. Due to continuous manipulation, we can also see a tear at the smile incision site. Management of cap tears depend upon the size. The small tears outside pupillary area can be left as it is, while for the large tears we can apply bandage contact lens. Tears can heal with a faint scar. There is also a risk of epithelial ingrowth. And for the beginners, they should use a 4 mm incision size. So to summarize, SMILE is a new technique with little learning curve. However, complications may occur like any other. So careful planning is important. Dark spots are sites of incomplete femtodissection. Examine the lenticule and ensure that no fragment is left behind. Results of SMILE varies from surgery to surgery and depends upon various factors. For all surgeons, complications happen. It's just how you deal with them. Each challenging case is a lesson, which if managed properly will keep a surgeon smiling after SMILE. Thank you.
Very nice collection of all these complications. Initially it does happen if you have too much of fluid on the surface, then risk of suction loss is there. If there is dry surface, then you get these dark spots and all that. Nice, and in the end, a nice photograph.
Thank you, sir.
Next we have Rohan Mehra?
Lenticule.
Okay, we'll have him later. Then Niti Gupta, she was here now.
Stevens-Johnson syndrome and its more severe variant, toxic epidermal necrolysis, belongs to the same spectrum of immunological disorder affecting the skin and mucous membrane. This may affect multiple organs and can be fatal. Around 50 to 88% have ocular involvement ranging from conjunctival hyperemia to complete sloughing of the ocular surface and eyelid skin. If not treated in the acute phase, this may lead to keratinized lid margin and limbal stem cell deficiency in the chronic phase and lead to ocular blindness. The use of amniotic membrane transplant within the first week of diagnosis of Stevens-Johnson syndrome or 10 in moderate to severe cases may prevent chronic blinding complications. Many techniques of amniotic membrane grafting in Stevens-Johnson syndrome is described using a Procara ring or placement of sutures or glue under general anesthesia, which are either expensive or not feasible as the patient are very sick. We will be showing a very simple technique of amniotic membrane grafting, which is done bedside without the help of suture or glue and only under topical anesthesia. This technique was first described by Dr. Sahil Goyal. So first we need to form a symblyferon ring, for which we require an infant feeding tube number 6. We mark 9 centimeters on this infant feeding tube number 6 and cut at 9 centimeters. One end is dilated with the help of a punctum dilator and the other end is cut in a beveled fashion. The beveled edge of the tube is then inserted into the dilated part to form a ring. Another ring is formed in a similar fashion. So this is a fresh amniotic membrane which is procured from a seronegative mother who had undergone an elective cesarean section after taking an informed consent. The amniotic membrane is treated with betadine 10% for 15 minutes and then it is cleaned properly with the help of a saline. The epithelial side is placed upward and the ring is wrapped over the amniotic membrane, and then this ring with the amniotic membrane is placed safely in a sterile pack. We make another pack in a similar fashion for the other eye. At the bedside, the amniotic membrane with the ring is inserted in the eye after putting topical proparacaine, taking all the aseptic precautions with the help of a non-tooth forceps and lid retractor. The ring is then slipped on inside the fornix. And the amniotic membrane is then unfolded gently over the ocular surface, covering the lid margins and taking care that it does not tear. In the end, we check for proper closure and opening of the lids.
Very nice way of doing it. Only thing is that how do you, couple of things, how do you measure the size of the fornix into which this tubing is inserted?
So this is actually flexible ring. So it actually adjusts to the size. Usually we take 8 or 9 millimeters. If you think the eye is very small, then 8 mm. But then when you insert in the eye, it takes the shape of the fornix, so it doesn't matter, like we don't have to calculate the size. So we've done it in like around 8 eyes.
And over the skin, do you do anything or you just leave like that?
We leave like that. Actually, it helps in healing of the skin of the lid also.
So doesn't it fall once the patient...
The lid part will fall, but over the surface it will be the same. So actually it serves the purpose, and sometimes we have to repeat again if suppose it's very severe and it melts early. And like at the time of discharge, we remove this ring.
Okay, nice innovation.
Thank you.
Just 1 second. I don't do all this, but this is a small suggestion. It just occurred to me. Many years back, I used to do a lot of oculoplasty work.
Yes, sir.
And that time we used to deepen the fornix by putting in these surgical sponges we use in retina. We used to cut it, put it on the inferior fornix and take a bite and come out through this.
Yeah.
So that is something which is much more pliable than an infant feeding tube. And if you can easily form a ring, they are available in different sizes, 5 millimeters, 7 millimeters.
Sir, I think we'll have to give a block for that. Without giving a...
No, I'm not saying don't give a cut, but you can just make a ring out of that, and that will be more pliable, more flexible than even an infant feeding tube, and you will answer his question.
In a chronic condition, that may be better applicable, but in an acute condition when a patient comes, then I think this is a good idea. Yeah,
Thank you, sir.
Thank you. Next we have Dr. Ravinder. Yeah.
Thank you, Ravinder. Great cases, complicated. My only this thing is that the third case when you did, the ILM in diabetics tends to be very, very adherent. And it really doesn't come off the way it does for the macular hole in non-diabetic. So maybe, gently doing it with finesse loop, Artenos diamond dusted from the surface, rather than pulling it could be. But great cases.
I tried with finesse loop first.
Yeah, it didn't
and
come.
Created that, but it was not coming with, it was very long standing case, and I could do with the ILM forceps later on, but if there would have been difficulty, then I would have put PFCL, but I wanted to avoid it because it was a very big
PFCL in macular hole is best avoided.
Usually I don't use.
Wonderful presentation. Two things. One, because you were not talking, we had a focused attention to read everything carefully, so that was interesting. And the other thing which I noticed was that your first case you did unimanual, and second case you did bimanual. I think you demonstrated that both techniques are equally good if in expert hands, but such difficult cases I would prefer bimanual. I would probably use the cutter's egress fluid to lift up the membranes and then do it. I think wonderful presentation.
Thank you, sir.
Lenticule extracting hydrocannula for smile refractive surgery.
The authors have no financial disclosure to make. Ever since the existence of human life, our aim as a united community has been to make things easier, and in order to do that, one has to constantly innovate. What is innovation? Innovation is the art, science, or process of developing better solutions from existing inventions and ideas. It is the validation and exploration of ideas that others may have missed, rejected, or long forgotten. Innovation connects the dots. Similar innovations have led the evolution of refractive surgery, from radial keratotomy to PRK and microkeratome, to now the latest on the block, SMILE. In SMILE surgery, the lower interface of the intrastromal lenticule is created with the help of the laser, followed by the upper interface of the lenticule known as the cap. Finally, a 2 to 3 mm tunnel incision, usually superiotemporal, is made to link the cap interface to the corneal surface. This is followed by lenticule separation with the help of a dissector and extraction of the lenticule with a pair of microforceps. Here, we demonstrate the separation of the lenticule and its extraction by pulling it out with the help of a microforceps. But not every ride is as smooth and easy. If one is not careful, we never quite know when it ends up in disaster. If we take a look at this particular case, there is a marked resistance in the separation of the lenticule, which leads to a tear of the hinge in the tunnel incision. This resulted due to improper dissection followed by a tugging movement to retrieve the lenticule. Such complications are not uncommon. Going through the review of literature, there are multiple highly cited papers published in index journals showing lenticule extraction related complications making up for a majority of the total complications of SMILE surgery. This paper reports the complications of SMILE procedure with the study comprising 160 eyes and showing a complication in 43 eyes. A cap rupture during dissection was the most common complication in as many as 16.2% of the cases reported. So where did the idea originate? One day I had a severe earache and I went to my ENT friend for a checkup. He told me that wax is the culprit for the earache and removed it by irrigating my ear cavity and not pulling it out, which got me thinking, if the ENT can do it, then why not use it in ophthalmology? So I took this idea to my mentor, Dr. Gaurav Luthra, and we developed a hydrocannula to extract the lenticule, making SMILE surgery further less invasive and extracting the complete lenticule without any cuts and tears. The hydrocannula is of 23 gauge and it bends to facilitate its movement over the contour of the cornea. The curvature of the cornea was taken into consideration while designing the cannula, and we have been using it for over 12 months now. We have done successful extraction of the lenticules in 196 eyes over this period. Here are a few demonstrations which show how a simple idea can make a huge difference in the reduction of complications in smile surgery. Once the proper dissection of the floor and the cap of the lenticule is done, the hydrocannula is introduced and the saline is injected, which aids in smooth retrieval of the lenticule. This lenticule is now placed on the cornea to show the intact edges of the lenticule. Another example of the same technique, which is simple and reproducible, leading to the extraction of the lenticule in totality without any cuts or tears. Let us further examine how this works. So we commence the injection. The purpose of slow injection is to promote free flow. Now why is this important? To make this technique work, you have to localize pressure differential between the inside and outside. If you have anything blocking the entry side around the hydrocannula, you will get a closed space. The pressure throughout the volume will be uniform. You get lamellar flow coming out of the end of the hydrocannula, and that actually is going to generate reduced pressure inside versus outside. You can understand this if you think about the way an airplane wing generates lift. According to the Bernoulli's principle, the pressure is lowest where the fluid flow is fastest in lamellar flow conditions. In case we do not do a slow injection, a situation like this might come up. But here, the advantage one has is that there is good visualization of the lenticule, and we know the correct vector forces to be applied to remove this lenticule with the help of a forceps. Once we have understood the dynamics of the procedure, it brings us to our next question, which is, why is this lenticule so important? Over time, we have realized what the true potential of human tissue is. An artificially made clone of the human tissue will never be able to replicate what we can achieve by using an original human tissue. Way back in 2014, we started cryopreserving the smile lenticule for possible potential use in human subjects. And less than half a decade later, we started using it in construction of corneal stroma, therapeutic keratoplasty, keratoconus, and most recently in regenerative therapy. Who knows what the future holds and what new uses of the lenticule might come up in due course of time, just like the amniotic membrane and the stem cells, which have progressed leaps and bounds in human evolution, thus making it imperative that we retrieve each lenticule in totality without any tears and cuts, and we store it for possible future use, hence making our innovation extremely important and one that could possibly help many individuals for restoration of sight, leading us to call this lenticule my precious.
That was fantastic, Rohan.
Thank you, sir.
Very good. Has anyone else done it, or?
No.
So why don't you publish it?
Dr. Praful was there yesterday in the session, and he said that they have done it initially, but then they stopped doing it. We are in the process of publishing it. We are in the process of publishing it.
One thing, when you hydrate, sometimes there is a little bit risk of some extra hydration and causing some, so maybe for a few hours there can be some blurring, some fogginess because of fluid imbibing into the stroma. So, that's one thing, but that will be very transient, so that's not an issue. So it's a very good technique. Thank you.
See, I'm not a refractive surgeon, but just the dynamics of the fluid flow, I think that was the question I wanted to ask, whether you'll hydrate the cornea. Second, when you inject, do you go right up to the end of the thing or inject it halfway through?
No, sir, right up to the end.
So when you inject right up to the end, it is like the flow you get, either you go on the posterior plane or the anterior plane, so you either way is fine, so that the fluid comes either from below upwards or above downwards. So, and with that flow, the lenticule walks out.
Walk out.
Thank you. And now we have the last speaker, Dr. Vaibhav.
Next 5 minutes, you all will be witnessing PFCL assisted inverted ILM flap technique for large and recurrent macular holes. First case is a 59-year-old female presented with diminution of vision in right eye. BCVA was 6 by 60. Fundus examination revealed large full thickness macular hole. OCT showed stage 4 macular hole with basal diameter of more than 900 micrometers. Patient was taken up for 25 gauge sutureless vitrectomy. ILM was stained with BVG dye. Inverted ILM flaps were rolled towards macular hole edge. Plugging of macular hole was attempted, but as seen on intraop OCT, the flap failed to cover the hole completely. PFCL was then injected, and under PFCL tamponade, the ILM flaps were mobilized using 25 gauge loop towards the macular hole. And apposition was confirmed on intraop OCT. Fluid air exchange was done and PFCL was removed at the end to ensure flaps remain in position. Tamponade with C3F8 was used. Post-op fundus examination revealed closed macular hole. Post-op OCT showed closed macular hole and vision improved to 618 parts. Second case was a 50-year-old male who presented with full thickness macular hole, for which he underwent primary surgery with inverted ILM flap and C3F8 tamponade. 4 weeks post-surgery, patient presented with recurrent macular hole. Which was confirmed on OCT. Patient was non-compliant to post-op positioning. He was taken up for resurgery. PFCL was injected and ILM flaps were repositioned and mobilized using 25 gauge loop towards the macular hole under PFCL tamponade. Intraop OCT confirmed closure of macular hole. Fluid air exchange was done and PFCL was removed at the end to ensure flap stability. C3F8 tamponade was used. 4-week post-op fundus examination revealed closed macular hole, which was confirmed on OCT and vision improved to 612. While reviewing literature, I came across few articles. Vishal Agarwal et al. Did a comparative study between inverted ILM flap technique versus standard ILM peeling technique, where they concluded that inverted ILM flap technique had significantly higher anatomical closure and better visual outcomes. In this, they injected PFCL and under PFCL they fashioned ILM flaps towards the macular hole edge and rolled up inside the edge. Tin et al. Described PFCL assisted single layer inverted ILM flap technique for macular hole. In this, after fashioning the flaps, they injected PFO over the inverted ILM flap and repositioned the flap under PFO. And then at the end removed the PFO during fluid air exchange. Abdul Qadir et al. In their review article stated that there is robust data supporting inverted ILM flap as first-line management for large idiopathic macular hole. Other surgical options include autologous retinal graft, human amniotic membrane, and distal ILM flaps. So to conclude, PFCL-assisted inverted ILM flap can be used as primary approach for large, chronic, and recurrent macular hole. PFCL acts as an efficient third hand and intraoposity is useful third eye adjunct in achieving successful outcomes, and loop is a useful tool for performing such complex maneuvers. Thank you for your attention.
Nice video. I have a question.
Yes,
so you had re-surgery.
Yes, sir.
You did the surgery initially and the macular hole reopened.
Reopened, yes, sir.
So when you operated again, you were able to find the flaps
Yes, sir. They
again?
had unfurled over the...
Achha, so there were flaps all there?
Yes, sir.
Okay.
They had unfurled, sir. Opened up, yes.
Okay. So that's interesting because you got the same flaps back,
Same flaps back,
and
yes,
put
sir.
them together.
I was just wondering whether stuffing is so essential that you have to do a resurgery?
Not really. If one were, there is a question mark being asked now about stuffing. There was an era when everybody was stuffing everything. Now the questions are already being asked about the validity of stuffing itself. But I think it will take a couple of years to reach in the practice.
We usually place it over the hole. You usually don't stuff it inside because then the chances of type 1 closure comes down and the visual acuity is not that great after surgery.
So also because it forms a small sort of a fibrous plug, and it's been shown in subsequent multiple OCTs that actually you can see the neurosensory retina's layers getting together and vision improving, and they have done multifocal ERG showing at each of these points, but I don't know, it's time only will tell if that is really working, and that has actually been shown also for autologous retinal transplant being put in there, so that
Because in the first case, sir, we trimmed the flap because they were large flaps. Then we tried viscoelastic, so it was not getting over the macular hole. So finally we went with PFCL.
Thank you.
आपने लोड नहीं करवाया प्रिव्यू रूम से लोड नहीं करवाया प्रिव्यू रूम मेन
सभी लोगों को फ्लाइट अच्छा ठीक है ठीक है हाँ तो नो प्रॉब्लम So I would request Dr. Sandeep Saxena sir to please chair this session because yeah, please sir. Okay, sir, please. Dr. Anuj, can I request you to please be the moderator? No, please come, please come. So I think Dr. Ajay Arora and Dr. Vishali Gupta will be coming, shortly. They've just gone across and maybe in 5 minutes they're coming. So maybe in 5 minutes we'll start. And yeah. आप बैठो तब तक सर के साथ.
Sir, मैं तो आ गई sir. But I have to actually leave early because मेरे कल डिपार्टमेंट में पीजी एग्जाम है सप्ली वालों का. तो फिर शाम को जाके थोड़ा बोर्ड भी तो चक्कर मारना पड़ेगा. वो उसके बिना तो हेड ऑफ द डिपार्टमेंट परेशानी हो जाएगा.
हम तो ये सजेस्ट करेंगे कि जो बाकी लोग हैं उनके टॉक्स अपने होते रहेंगे, जो हैं वो अपने करते चले. सुनने वाला कोई नहीं, हम ही सुनने वाले हैं.
तो क्या करेंगे सर? रेटना में आज तक कभी ऐसा हुआ है कि आप किसी को सुना पाए हैं? है ना, सुन रहा है तू वाली है. भगवान ऊपर सुन रहा होता है और आप अपने आप से बोल रहे होते हो. This is the beauty of working in Retina. You have to, sir. You have to put multifocal IOLs to make sure people listen to you.
डॉक्टर साहब, आई फील कोई भी जगह नाश्ता करने जाएगा ना 20 मिनट फास्ट ट्रैक नाश्ते में और हाफ एन आवर.
Yeah, it's okay. We are not waiting. We are just hoping there is somebody.
स्टार्ट कर देंगे. वो और इसमें जो स्पीकर्स हैं वो अपना बोलते चले.
So to begin with, let us apologize because unfortunately or fortunately we practice retina. So therefore we have to get used to talking to empty chairs. So whoever wants to begin and go have a run, please go ahead do it.
लेंस पर ही रुक जाता है, फिर रेटिना तक पहुंच ही नहीं पाता है.
छन्नी है ना सर, वो लेंस इज अ छन्नी.
डीप हो जाता है.
Yeah, take your time. Take your time. It's okay. Absolutely fine. Absolutely fine. This is nothing new. या सर मैं कहाँ सोच रही थी कि सब लोगों में तो मुझे शर्म आएगी जाने में.
डॉक्टर मनीषा अग्रवाल इज देयर, तो आ जाएंगे.
यहाँ से देहरादून जाने में ना 4.5 hours लगेंगे ना. तो फिर by the time if I reach there even at 2:30 or 3 o'clock or maybe 4 o'clock, then I have to get my residents are also here. उनको भी तो हाँकना है, ये काम भी तो करेगा वो वार्ड में.
उनको भी लखनऊ तक टैक्सी के साथ में लेके जगह.
नहीं साथ में मैं नहीं लेके जा रही, पर मैं हल्ला मचाऊंगी ना कि भैया शाम को राउंड कराने के लिए पेशेंट की लिस्ट बनानी है, एग्जाम में कौन कौन होगा, क्या होगा, कैसे होगा. नहीं तो ऐसा काम ही नहीं होगा.
Good morning to the slim audience that is present here today. The first up we'll have Dr. Sandeep Saxena speaking on novel insights into the pathogenesis of photoreceptor ellipsoid zone disruption in diabetic retina. So please.
So I'll be speaking into the novel insight into the pathogenesis of the ellipsoid zone disruption in DME and diabetic retinopathy, and based on my discoveries, I had the privilege of presenting in part at the Harvard Medical School and at Oxford University as these discoveries became prominent. So now the translational research in diabetic retinopathy is basically focusing on the structural alterations on the biomolecules and how these structural alterations relate with the biomolecules. Now, for the past decade or more, for DME treatment, the focus has been onto the CST and CAT, and people were not looking beyond that. But now, since we started this out, people are now focusing on the outer retinal layers. And just to recapitulate for the audience, the outer retinal layers are 4. Of those, the one which are relevant for this lecture are the external limiting membrane and the previously known OS junction or the ellipsoid zone. And I'll be basically featuring on these two. So it was Dr. Spade and Kurkio who came out with the concept on tadpole retina that the IS-OS junction was indeed the ellipsoid zone of the photoreceptor, and they proved it on a layer by layer analysis as shown in this diagram. So now the OS junction is currently known or practiced as the ellipsoid zone of the retinal photoreceptor, and that holds the structural integrity of the retinal photoreceptor. A Japanese group showed that with euthanasia in a rat model, the visibility of the ellipsoid zone or decreases, and they hypothesized that this might be due to the biological activity because that is rich in mitochondria. Now the clinical implications of my work are basically focused on the external limiting membrane, and we all know that the outer blood retinal barrier is formed by the RP cells, and the inner blood retinal barrier is formed at the level of the retinal vessels. But a study in 2010 showed that the external limiting membrane also has the same kind of tight junctions as has been shown or demonstrated in the outer and the inner blood retinal barriers. And this is basically due to a protein by the name of occludin, and that has been demonstrated in the external limiting membrane of the retina and in the rat retina and the monkey retina. And they suggested that the ELM junctions could be a novel regulatory target in the treatment of DME. So in 2011, we observed that how the ELM and EZ were behaving in terms of the serum VEGF and the ICAM1 levels. So we focused for the first time that how the VEGF, the angiogenic molecule, and ICAM1, the inflammatory molecule, how they were influencing the ELM and the EZ of the retina, and we came out with this clinical discovery of ELM as the first retinal structural barrier, and we showed for the first time that the ELM disrupted before the EZ disruption happened. So ELM was serving as a sort of a barrier which kept on with the photoreceptor integrity. But as this barrier disrupted, subsequently the ellipsoid zone also disrupted. And so we came out with a classification system which was published in 2013, 10 years back, where we showed that the grade 0 there was no disruption of the ELM or the EZ. In grade 1 there was the disruption of ELM only, and in grade 2 both the ELM and the EZ were disrupted, and this went hand in hand with the visual acuity. So we were able to come out with a simple grading system as well as that reflected the basic pathogenesis of the ellipsoid zone disruption, and that holds the key how the vision goes down in cases of DME. We elaborated it further because we were using Zeiss OCT. So we came out with that global kind of a concept that whether the things were restricted only to the subfoveal area only, or it was a global kind of phenomena. So then we focused on the ellipsoid zone only and came out with a grading system of grade 0 an intact ellipsoid zone, grade 1 with focal disruption, and grade 2 where there was a generalized whole soul disruption of the ellipsoid zone. And that also went well with the visual acuity. So now what was intriguing was, and as I presented at several international places, people asked that what was happening once the anti-VEGF was given. So I took this work further, and we used bevacizumab in about 138 cases or so, and then we tried to see how the things were working out. And as expected, the same thing was happening, that as the anti-VEGF was put on these successive months, in 3 months' time it was seen that the ELM was restoring, and then it was followed by the EZ restoration. And so here you can see that both the ELM and the EZ are gone, And on the subsequent post-treatment, you can see that the ELM has restored back in the subfoveal area, whereas the EZ is in the process of restoration. So it has restored at places which you can see right here, and still in the process of restoration in the rest of the areas. So that sort of corroborated with our initial discovery that ELM holds on as a structural barrier, and subsequently as the ELM disrupts, the ellipsoid zone disrupts, and then as the ELM starts to restore back and gets restored, the ellipsoid zone restoration also comes back into place. So we have gone further, and we have tried to see if the ellipsoid zone works as a structural barrier, and through the area under curve analysis, we found an excellent area under curve of 0.95. So that means that ellipsoid zone also works as a structural barrier vis-a-vis to the visual acuity in cases of DME after anti-VEGF therapy. So if the ellipsoid zone is restoring back as the anti-VEGFs are being given, the patients can be told that they have a better chance of visual recovery vis-a-vis in those cases where the things are not restoring back. And we found that this ellipsoid zone integrity holds good with the disorganization of the retinal inner layers as well as the retinal nerve fiber thinning, and we came out with these publications. Now subsequently we have been focusing on how to popularize this concept, which is in the process of growing up, and so we published a few of these recent papers highlighting these facts, that external limiting membrane serves as a retinal structure barriers, and we have been trying to focus on the external limiting membrane and the ellipsoid zone integrity in cases of DME. And then in our own journal we also came out with a publication on focusing on these layers. So we have tried to highlight the basic pathogenic mechanisms, how these things happen, and how the ELM and the EZ disrupts due to an increase in the VEGF levels, and how they are restored back after anti-VEGF therapy. We have also published a couple of review articles on the subject, and these are available free online. Thank you very much for your patient hearing. Thank you.
Thank you so much, sir, for your insights. Any questions?
Dr. Sandeep, I have a small question.
Yeah.
At what point of time you will decide, after having starting treatment with anti-VEGFs, that this ellipsoid zone may not recover? Do we have any markers which say?
Well, I have not worked on that because many a time the ellipsoid zone will come quite near, as for the macular hole surgery also. What we have seen is that although in some of the cases that total restoration is not taking place, as I had shown in my structural biomarker slide, but as the ellipsoid zone starts to recover or restore back, the visual acuity starts to improve, and so this sort of interrelation between the ellipsoid zone and the visual acuity holds good in about 95% cases or so. So I don't have a sort of a cutoff mark, but then I can go back into that area under curve, and I can do a cutoff value also, because for this area under curve in the statistical model we do have a cutoff value, so I can go back and can load back to you. Okay, thank you.
So is this the regeneration or the restoration?
No, this is the restoration of the. So as it comes back, So then things. So it's not a regeneration, because the Mueller cells and this photoreceptors have just sort of gone away, one can say, and then things start to just restore back. And as these tight junctions are restored back, all these things come back into place.
Sir, any difference in using steroids? Do you see the same thing happening with intravitreal steroids also, as compared to what
our work has been focused? Our work has been focused on the anti-VEGFs only. So I don't have a sort of an experience that how these things are basically behaving. So my work has been focused on anti-VEGFs only.
What Sangeet asked, can we differentiate between restoration and regeneration just by looking at OCT?
No, it's.
I think that possible.
So it is not possible just by looking there, but what the literature mentioned and these animal studies have shown, it's basically the restoration and not the sort of regeneration of these things. Okay.
Thank you.
Thank you so much, sir. Dr. R.P. Singh, I don't believe sir is here. So I'll be starting with the next talk.
So next is Dr. Anuj. He'll be talking on navigating CSCR in modern age. Anuj is a dynamic young vitreoretinal surgeon from Dehradun, and he is working at Amritsar Eye Clinic.
Hello, good morning everybody. So I'll be talking about navigating CSCR in the modern age. Things have changed a lot by the time that we had first discovered CSCR and how we are looking and treating it at today. So when we talk about CSCR, what is the first image that crops up in your head? And that is of usually a male patient, somebody who's between 30 to 50 years of age, has type A personality traits, suffering from stress, corticosteroid exposure, and usually complains of a small amount of diminution vision with a black shadow in the central visual field of a month's duration or 15 days duration. What is important is that we should understand that recurrent active episodes of CSCR are common in about 50% of the cases. So any patient who develops CSCR should be on follow-up actually for life, for looking at recurrences in the subsequent periods. So the initial classification of CSCR was simple. It was divided into acute and chronic cases. Acute cases usually tend to resolve between 3 to 6 months, and if the subretinal fluid persisted for more than this period, we labeled it as chronic CSCR. When we look at when I was basically compiling this presentation, I looked up a lot of articles and looked at the various therapies and treatment modalities that were available for this condition, and I came across so many of them. So now the first thing that I was told, when you have so many treatments for a condition, you should understand that the treatment is very difficult and may not be 100% effective in a majority of cases. So out of all these treatments, I have personally had experiences with, obviously everybody knows that observation is for acute CSCR is the best, with focal laser, anti-VEGF agents, spironolactone analogs, and sub-threshold, we don't have a micropulse laser, but sub-threshold laser over the fovea and over the diseased RPE when we have multifocal leakages. So multimodal imaging has changed how we are looking and evaluating CSCR today. OCT has been the backbone of evaluation. In cases of acute CSCR, you usually see smooth, dome-shaped elevation of the neurosensory retina, no presence of any intraretinal deposits, and there's an associated serous PED, which is seen in acute cases. When you look at chronic cases of CSCR, long-standing SRF leads to the presence of a sawtoothing of this smooth dome that we see in the acute cases. There is sawtoothing over there. There are presence of intraretinal deposits. You may have cystoid macular edema also, and there is a presence of what is known as a double layer sign. So what is this double layer sign? A double layer sign is a flat irregular pigment epithelial detachment, as we see over here, and there may be two forms of fluids that we might see. It may be homogeneous or heterogeneous. When we have a heterogeneous fluid in this irregular PED, then there are more chances that there is a presence of a choroidal neovascular membrane over here, and in such cases we tend to relabel or reclassify these cases of chronic CSCRs as pachychoroid neovasculopathy. So moving on to the role of fundus autofluorescence in CSCR, basically fundus autofluorescence is dependent upon the RPE, and in cases of chronic CSCR we have a lot of RPE abnormalities, and in cases of FAF we see that the amount of area that was involved with the CSCR or the disease is much more than what we see clinically. This is evident in both cases, bilateral CSCR in this as well as unilateral right eye CSCR chronic in the right eye. When we looked at the OCT of this patient, we found that there is still presence of subretinal fluid over here in the central macular area, and there are features of retinal atrophy such as ellipsoid zone disruption, the loss of the external limiting membrane, and the thinning of the outer nuclear membrane. The fundus fluorescent angiography in CSCR is an indispensable tool because we have to find the site of leakage in cases of chronic conditions, and leakage can only be detected on an FFA and not in terms of an OCT angiography. So this is the typical case of acute CSCR. You get the leakage as an in-plot sign or a smokestack appearance. We may have multifocal or multi-point leakages, as is pretty evident over here when you see the two dots over here, along with the diseased RPE right in the central, is there a pointer? Right in the central macula over here, along with the disruption of the RPE right here. So I'll talk about something which two cases that I came across, a fibrinous CSCR. This was around a 42-year-old male, the right eye being absolutely normal. When you looked at the left eye, this was the clinical picture that came out, and we did an OCT. So on the OCT, what is evident over here is with the yellow arrow, you can see the double layer sign over there. The elevation of the RPE, RPE, and the Brooks membrane is left behind. It's an irregular PED. And although it is a homogeneous PED, there is no evidence of any heterogeneous fluid or fibrin-rich fluid in the sub-RPE space. Fibrin is there in below the neurosensory retina, and also you can able to make out the cystoid spaces in the outer retina over here. I went ahead and gave an intravitreal anti-VEGF for this patient, diagnosed him as a case of fibrinous CSCR. The only reason for me going ahead with an anti-VEGF at this point was because I was seeing cystoid spaces in the outer retina, thinking it may be a chronic CSCR, so I went ahead with that, and 15 days after the injection, we noticed that the the cystoid spaces had completely disappeared, and the PED also to a certain extent was tending to stabilize and flatten. At 15 days post-injection, there was not much improvement in visual acuity because it was a little too early, I would say, at this point of time. 6 weeks post-injection, there was a diminished fibrin and flattening of the PED, which was clearly visible over there. The black arrows, you can see that as compared to the initial photograph, the amount of fibrin has diminished a lot. At this point of time, we did an FFA for the patient, and we were able to see that there were primarily multiple sites of leakage underlying the papillomacular bundle, 2 areas of main focal leakages along with a disrupted RP around that area. We did a focal laser to this patient, basically to the 2 major points, and then subthreshold laser over the whole of the diseased RPE. And at 1 month following that, this was the clinical picture and the OCT picture that was seen. The foveal dip has started to come back, and the fibrin has diminished a lot. And at for the 3 months that I've been treating him, his visual acuity has improved from 3/60 to 6/24. At this point, however, we can see that there is still again a rise in the PED that I can see in the lower picture, and we might be planning ahead with an repeat intravitreal injection for this patient. This is a second case of fibrinous CSCR, 43-year-old male. He complained, so a little, I would like to apologize for the quality of pictures in this patient. We lost the OCT records for him. There was a diminished vision in the left eye since the past 1 month, and the visual acuity was 6/18. He was diagnosed elsewhere as a case of CNVM and was advised for an anti-VEGF injection. When I looked at him, the main thing that I looked at was the age, and that would not be the first diagnosis that would come to mind when you look at the age of the patient. So we did an FFA for this patient, and the FFA was more in favor of a chronic CSCR rather than a CNVM. So we started him on spironolactone analogs. I personally have had a good experience with spironolactone analogs, aplenirone per se, but obviously that is a big question to be asked to the audience as to what is their experience with this drug. So after starting in on aplenirone, I asked him to review back in 2 weeks with serum potassium levels just to check whether there's any elevation of these. To my surprise, this was the first patient where I found that the potassium levels were elevated, and we stopped aplenirone at this point of time. The fibrin had decreased, and the visual acuity at this point of time had improved from 6/18 to 6/9. So we stopped aplenirone, and now after 1 month of stopping aplenirone, the visual acuity is stable at 6/9, and the serum potassium levels have come down to 4.7. We did an FFA, and we went ahead with focal laser for this patient. Another case that I would like to show over here was a case of an atypical CSCR. This was a 28-year-old female, newly married, was a little anxious because the visual acuity had come down to 6/60 in the left eye. Upon clinical evaluation, yes, we were able to look at the neurosensory detachment over here, but what was surprising was that there was an inferior bullous detachment that was also developing. We carried out an OCT, and you can see the amount of elevation of the neurosensory retina in the inferior half, which is more evident on this video. No fibrin was noted, but the serous elevation is pretty paramount. So we went ahead, we did an FFA, we found the focal leak within the foveal avascular zone. We did a focal laser, and 2 months following the focal laser, the visual acuity improved from 6/60 to 6/12 in this case. Another case was that of a chronic CSCR. This is the first patient where I actually did full multimodal imaging, and we located all the areas of the disease, RP. As a 60-year-old male, the visual acuity in the right eye had decreased for the past 6 to 8 months at 6/18. There was concomitant cataract also in this patient. The sawtoothing is pretty evident over here along with the fibrous PED. Initially, I went ahead and gave the patient a brolucizumab because of the subretinal location or the subfoveal location of the PED. And 3 weeks post bevacizumab injection, we can see that the height of the SRF has come down, and the height of the PED is almost negligible. At this point of time, we went ahead with cataract surgery for this patient, and the visual acuity improved to 6/12. After 6 months, the patient presented to us again with further decrease in vision. Similarly, the SRF had increased in size, and we went ahead and did focal laser for him. So this was a clinical scenario that I would like to show, that not all cases are CSCR. This is a 58-year-old male. He had a history of rhegmatogenous RD in the left eye, which was treated, doing well in the left eye, but the right eye, he said that the visual acuity was less, 6/18. It's been more than a year now, and the refractive correction was somewhere around -3.5 diopter sphere. He showed all the traits of what we would look for in a CSCR patient, with type A personality traits, and he said that I was unable to sleep at night because I've recently lost my job. We thought we maybe misdiagnosed him as a case of CSCR, gave him an injection. Post-injection, his subretinal fluid was absorbed, but when I look back at the patient, I think I should have labeled him as a dome-shaped maculopathy earlier rather than treating him as a chronic CSCR. So on the basis of multimodal imaging, I think we should look at and reclassify CSCR. This was given by Dr. Jay Chablani et al. And they divided CSCR into simple, complex and atypical depending upon the areas of the RP abnormality. If more than 2 areas of 2 disc diameters of RP abnormality was noted, they were noted as complex, others were called as simple. You divide them into primary, recurrent and resolved depending upon whether the patient is presenting to you for the first time or if there is any history of RP abnormality that was noted. If you ask me, would I classify each patient as this case? I think it's a classification that will be difficult to use in the clinical scenario. But yes, when we look back and reanalyze patients with chronic CSRs, we should maybe classify them in this manner. Just to summarize, when a patient comes to you with CSCR, what are your treatment options? If the symptoms are less than 3 months, observation is obviously the best thing, and look for any exogenous factors that may lead to exacerbations of the CSCR. Greater than 3 months, you may have to use a combination of any of the 3 modalities as mentioned. Thank you.
Another important tool is the angio-OCT in the management of these chronic patients.
Yes, sir.
So wherever you have doubt of whether the CNVM is there or not, just do angio-OCT and will give you an idea whether you have to give anti-VEGFs or do a subthreshold laser.
Right. So they say that there's about a 95% correlation between the double layer sign along with heterogeneous fluid with CNVM being present on an angio-OCT.
It's an additional
yes,
tool, right?
Yeah, it should be looked at.
Because you see 2 things, Anuj. One
Yes,
is what Sangeet said, when you have a double layer sign, you have to think in terms of choroidal neovascular membrane being present there. And it's been shown many years back when they started doing transpupillary thermotherapy for choroidal neovascular membrane.
Yes.
And they found that actually you can worsen the CNVM in these cases.
Okay.
So that was way back in 94, 95 when this was done.
Yes,
so in all cases where we are planning to do a subthreshold laser and you are suspecting a choroidal neovascular membrane, you have to be extremely wary of things.
Right,
so an octa would help you to define the choroidal neovascular membrane. So we've had cases where we treated with injections, made sure that the CNVM subsides, and then went ahead and did a micropulse. So recently had a patient where instead of going for 5% duty cycle, we went for 10% duty cycle, and then we did an autofluorescence on Merante, and we found that there were spots which you could see on an autofluorescence.
Right,
and one of the patient actually started complaining of it. So I'm just praying that his symptoms reduce. Because so therefore same thing with the subthreshold laser. We'll end up seeing those spots on the RP in this thing. So better you have to be extremely careful with that.
Thank you, sir.
Micropulse we go transfoveal. But the basic problem is, I think Chablani said that 10% duty cycle can be used as part of this thing. And we found that with the 10% duty cycle, we end up creating spots on the RP which are not visible clinically but are visible on autofluorescence. And one of the patients actually, because these are tightly packed spots, so there's no spacing between the spots. So when you have tightly packed spots and you are able to see them, the patient said, "Sir, mujhe kuch dot dikh rahe hain." And when I saw his autofluorescence image, I showed him that these are the dots. But he fortunately did not ask me how did they appear. No, I'm really scared. So I have stopped using 10% duty cycle for the macula because 5% duty cycle have never got this problem. But 10% duty cycle I use beyond the arcade.
Have you ever had a drop of vision after using a 5%?
No, not with a 5% duty cycle. In fact, yesterday I showed a patient where actually CSR, the neurosensory detachment increased on the 5th day, and after 2 weeks it subsided. It was a dentist. I saw the OCT, he never complained anything.
For the recurrence of SRF?
So recurrence of SRF, so I've treated him for the last 4 years 3 times. Vision is 6/6. He was in epineuron. After epineuron he never subsided, but with micropulse he's absolutely flat. So we have not been doing contrast. We recently started. I've recently started doing this field also. To answer your question you asked yesterday, I've done it on diabetics, but I've not done on CSR patients. So, but we'll do that. Thank you.
It's okay. I asked him some questions.
So, Dr. Vishali and Dr. Manisha have to present, but अगर आप लोग present करेंगे हमारा audience खत्म हो जाएगा. नहीं. Indranil, you are staying for the session.
You know, we started with, there were 5 of us actually. Where did Dr. Sandeep go? So there were 5 of us when we started, you know. Yes, so there were 5 of us, including him. And then now there are 4 of us. And please, we won't let you
Let's
also
all go.
That's a better thing.
हम वीडियो तो नहीं
We started with 5 people.
Have somebody outside directing.
Showing a video which has retinal detachment in 3 complex situations. ऑडियो भी है.
वैसे है ना आप लोगों को एक टाइगर यहाँ खड़ा कर देना चाहिए सब कुछ नहीं होता
टाइगर छोटी है.
मतलब
टाइगर से ऊंची कभी का पहन के बैठ जाती है.
I present a 23-year-old female patient with diminution of vision, pain and redness in the left eye for last 1.5 months. She also gave a history of wiping her face with a towel while sitting on a hilltop. The best corrective visual acuity in the left eye was 6/9 N8 with multiple linear foreign bodies in the anterior chamber and deep corneal stroma. She underwent an anterior chamber wash with removal of multiple linear foreign bodies and was found to be stable post-operatively. She, however, had recurrent episodes of vitritis with a drop of vision which would respond to oral steroids, however, recur on stopping them. There were extensive exudates in the pars plana with peripheral tractional retinal detachment and vitritis. Ultrasound biomicroscopy showed thickened pars plana with multiple hyperreflective linear structures suggestive of query caterpillar hair. She was planned for a pars plana vitrectomy 3 weeks after a 360-degree laser photocoagulation. She underwent an encircling band and a lensectomy was done, sparing the anterior lens capsule. PVD induction was done and the vitrectomy was completed. There were peripheral retinal detachment with posterior laser chorioretinal atrophy which was well seen. Multiple caterpillar hair were removed from within the exudates in the pars plana, leading to a few retinal breaks. This was followed by fluid air exchange and laser was done to the retinal breaks, followed by silicone oil injection. 3 months later, she underwent silicone oil removal with secondary IOL implantation. Her last follow-up at 2 years showed a vision of 6/9 N6, which she maintained in the left eye with no history of recurrence of inflammation. My second case is a one-eyed 40-year-old male patient with a vision of PR inaccurate and a double trouble in the form of a corneal opacity and retinal detachment following a wooden stick injury and corneal perforation. The corneal button was removed with anterior vitrectomy and a temporary keratoprosthesis was placed. View through the keratoprosthesis showed a closed funnel retinal detachment with extensive PVR changes. A small bubble of perfluorocarbon liquid was injected to open the funnel, however it failed to do so. Membranes were peeled to open the funnel. A small foreign body was found floating in the vitreous cavity, which was delivered out, and more membrane peeling was done. There was leakage through one of the holes of the keratoprosthesis, and the suture had to be replaced with glue applied over it to stop the leakage. This glue, however, got smeared over the keratoprosthesis and had to be scraped, increasing the already existing double trouble. Retina failed to open up in the superiotemporal quadrant, hence an anterior relaxing retinotomy was done. Subretinal gliotic bands were removed, followed by laser photocoagulation, and perfluorocarbon liquid silicone oil exchange was done. Finally, the corneal transplant was completed. At 6 months follow-up, there was a well-attached retina with a vision of 636 N36, and this made the patient ambulatory. My last patient is a 47-year-old diabetic female patient with diminution of vision in the right eye for last 1 month, with a triple trouble in the form of proliferative diabetic retinopathy, full thickness macular hole, and a combined retinal detachment in the right eye. The vision in the right eye was as low as counting finger at 1 meter. She underwent a pars plana vitrectomy followed by fixation of a chandelier light. Bimanual dissection was done of the fibrovascular membranes using forceps and scissors. The fibrovascular membrane was then gradually detached from over the optic nerve head. A meticulous removal of all the residual membranes was done, and the last bit was removed with the help of the cutter. A retinotomy was then made in the superior quadrant to remove the sheet of the subretinal gliosis, followed by fluid air exchange. BBG dye was then injected under air, followed by restarting of fluid infusion after 30 seconds. ILM peeling was then performed using the pinch and peel technique without using the perfluorocarbon liquid. This was subsequently followed by fluid air exchange again, and laser photocoagulation was done to the retinotomy site. Silicone oil injection was then performed. At 2 months follow-up, the patient showed a well-attached retina with a type 1 closure of the macular hole. The patient recovered a good vision of 624 N18 in the right eye. RD may present in various complex situations, however, if managed appropriately, may result in good visual outcomes. Thank you.
Very nice. Very nice.
Thank you.
It was nice to watch.
Just one thing, like in these chronic detachments, like in PDR cases, one important step before doing a air fluid exchange is to do a fluid exchange to get rid of the, and then settle the retina.
The patient you did a relaxing retinotomy, did you put in a belt buckle?
Yes.
Because that sometimes
Yeah.
helps in these cases
Yes.
where you're not able to do it, might actually help.
Absolutely, sir.
Yeah. So, ma'am, let ma'am. But they, Dr. they have promised to stay. आप request करेंगे मान So Dr. Vishali needs no introduction. A doyen in both uvea and retina. Professor at PGI. She'll be presenting vitrectomy in diabetic retinopathy, ma'am.
Thank you. Thank you, and sorry for skipping the queue. My topic was 3D vitrectomy for diabetic. So before we start to the surgical, important is to establish the goal, get a very good informed consent. Preoperative PRP wherever possible in the periphery is always helpful, reduces the formation of intraoperative fibrin. Preoperative, it's written perioperative because sometimes you would give it at the conclusion of the surgery, but those patients with traction, anti-VEGF before the surgery, which is about 3 to 5 days on an average, but important that you are ready, everything is ready for surgery before you inject. You can see this patient after injection and then post vitrectomy. Good metabolic control, choosing the right instrument, follow a plan, control intraoperative bleeding, right there and then. And this is how I'm going to show a couple of videos. The principles of diabetic vitrectomy are actually very simple. You clear the hemorrhage. The hemorrhage which is in the vitreous, in the core, and then you tackle the membranes one by one. It's important to divide them into different segments rather than trying to do en bloc. I use proportional reflux all the time. So when I'm insinuating my cutter, I'm using the proportional reflux to create the plane which separates it from the retina, divide it into different segments, and then each of these segments can be tackled very carefully. We now have such amazing cutters, and now we have up to 20,000. I did it last week. So generally, it's very rare that I use a second instrument for my diabetics patients. Most of my patients are, a single instrument surgery. Sometimes the peripheral VR adhesions can be tricky in diabetics, and that is what requires a very meticulous peeling, because you don't want to leave anything behind. Now, there I found that once you have taken a good care of your posterior pole and you go to periphery, you can use a forceps very gently just to nudge it, because this is the area where insinuating the cutter is not very easy. Though diabetics do not have too many times the changes in the periphery, but a little nudge using the forceps just to lift the membrane a bit, and then using the your cutter to cut those membranes, fragment them into small fragments, peeling them at that time. So but you just have to be, whether you are insinuating proportional reflux or you are nudging it with the forceps, your force has to be very, very mild, and that is only with the experience you will know the right amount of the nudge which does not cause the break, but which is able to lift the membrane off the surface of the retina. And you can see the rest of it is kind of easy. You just trim it and don't leave anything behind, and then you can, each of these segments you have to tackle independently, and the principle essentially remains the same. Earlier we used to leave some of the nodes or something, and now with these cutters you can actually go right on the surface of the retina, remove everything. So you don't have to leave behind any nodes or anything, like even on the optic disc. You can go close to the disc, cut whatever you want, and you know, it just works very well. Just you have to know that all the meticulous dissection has to be done in different fragments. Don't try to go on one go and try to pull away everything from the disc. This is just to indicate the use of the forceps, which I do very rarely for those which have very, very firm adhesions to the surface of the retina. And this is the pre and the post-op. So with 27G cutter, actually this has become even more fun. I would just say fun, because you can see here, you can, you know, this is just to create a plane, and that is the key for diabetic vitrectomy. The plane from where the cutter starts entering into this is the one which is going to decide how your surgery is going to proceed. So if your plane of insinuation is right, all you have to do is use your equipment. I use only cutter, proportional reflux, and very rarely forceps to elevate it from the surface of the retina. Like this one will be proportional reflux, just elevate, start cutting it, and then, you know, after that. And this is changing the direction of the cutter. With cutter, you know, you can move it in any direction, right, left, center, wherever you are, which with scissors that manipulation is less. But again, it depends on your expertise and what works the best for you. But cutter, you just change the direction in whichever direction you want to do, flush it on the surface. This is 10,000 cuts, as you can see here, being used to clear. I'll just move it fast forward. This is the laser to control the bleeding, but honestly you can do diathermy, you don't have to always apply laser. And this is just to show that sometimes you will have to use it from inside, sometimes from outside, but just make sure that whatever you are doing, you are not inducing iatrogenic breaks. And that is one of the important steps in diabetic vitrectomy, is to be gentle, be under control, and do whatever works best for you. And this is at the end of the surgery. This is again a video just to show the directional level of with which you can go. I think I'll skip some of these. And even for the very complex RDs, like if you are following, this is the rollback technique, where you can either lift the membrane and then everything starts coming into the cutter, rather than you changing the direction of the cutter. Again, I'm going to fast forward. MIOCT is fine, but there is nothing if you don't have. It's just that you exactly know where you are entering. This is the most important step. Even when you feel it is complete, always do triamcinolone to look, because vitreous cases is very, very common in diabetics. And this is my last tip: live to fight another day. If the things are not going well in the beginning, for the beginners, you may realize that surgery is not working. So, you know, do the limited, close it. You can always come back another day, because if your media is too hazy, the bleeding is not getting controlled, don't try to keep doing things when your retina is not clearly visible, because that can cause more harm. So diabetics is like CHAMP, clear view, separate the hyaloid, anti-VGF, multiple surgical techniques, whatever works best for you, and pre-operative PRP is really helpful. Thank you very much once again, Ajay, Renu, Sangeet, for giving me the opportunity to speak earlier.
Thank you, ma'am. And we would like you to stay back and give the comments on other presentations. You have been a champ.
हमारी 2:30 flight है.
Indranil, come. Thank you, ma'am. Thanks a lot. Wonderful tips, beautiful videos. And so Indranil presenting on posterior segment complication in cataract surgery.
A very good morning, everyone. So I'm going to speak about something which, as retina surgeons, we see on a daily basis and very regular, and something very common in our practice. So cataract surgeries are one of the most common intraocular surgeries with high patient expectations, and as we are seeing in the daily meetings, it's almost like a refractive surgeries, and any surgery has its own share of complications such as an intra-op complications or post-operative complications. So we'll be discussing about needle stick globe injuries, PCRs, drops, surgical aphakias, CME, endophthalmitis, TARS, RDs, and the most dreaded expulsive hemorrhages. So needle stick globe injuries are iatrogenic with 0.1%, commonly seen in axial myopia eyes, deep socket eyes, or if the patient's been uncooperative. They can range from lacerations to perforations to penetrating injuries, lacerations being the milder ones, perforations causing a hypotony, and penetration ones causing a raised IOP, sudden pain, and vision loss. So perforations or penetrations are the elective procedure needs to be abandoned. There will be a vitreous hemorrhage. You can observe for some time, the hemorrhage starts clearing, laser the brakes immediately. Hemorrhage doesn't clear or associated with an RD, one needs to progress with an VR surgery. PCRs can occur at any stage during the surgery, can range from 0.45 to 14.7%. Early recognition is vital to restrict further damage. Vitreous in AC causing attraction, vitreous in surgical wounds, these are best avoided. Nuclear fragments in vitreous cavity, IOL displacement or dislocation, these are the aftermath of the PCR, and that's when everyone gets very panicked, and of course an RD. So these are a few images to show the vitreous show coming through the PCRs. And so the best thing is once it's happened to be alert to the situation. A good anterior vitrectomy, although a pars plana route holds a much higher value, ensuring that all surgical wounds are free from the vitreous. Do not fish for the dropped contents. Proper closure with sutures, avoid hypotony, and get an urgent VR opinion. Various situations of a nucleus drop that can lead to inflammation, raised IOPs, corneal edema, CMEs, vitreous hemorrhage, retinal detachments. IOL drops, which can be an early dislocation, which if occurs less than 3 months, late more than 3, which can happen due to an asymmetric haptic placement, capsular rim phimosis, capsular bag contracture, or progressive zonulopathy. We have various techniques to conquer surgical aphakia, be it an in-sulcus IOL, AC IOLs, iris claws, SF IOLs, sutured, sutureless. This was one of our techniques published in IGO on Feb 2021. CME, it can be asymptomatic or symptomatic, complicated or uncomplicated. Early detection leads to a favorable diagnosis, where about 4 to 41% of OCT or angiographic evidence. Incidence increases in cases of PCR, vitreous loss, vitreous traction, iris trauma. Main etiologies being an endogenous inflammatory mediators or surgically induced, can resolve spontaneously too. Risk factors being type of cataract surgery, age of the patient, vitreous changes, retained lens contents, uncontrolled diabetic, uveitic eyes, RVOs, ERMs, topical PG analogs, acute if within 4 months, late if it has been more than 4 months. So this is an angiogram to show the early and late CMEs with the corresponding OCT. Management, NSAIDs, a stepwise steroid approach, combination of NSAIDs plus steroids, carbonic anhydrase inhibitors, anti-VEGF therapies, or surgicals being a YAG laser, vitreolysis, or a pars plana vitrectomy. This is now the dreaded ones, the endophthalmitis, where a poor surgical wound can always harbor such kind of a complication. Incidence varies considerably. International pool data being 0.128%. Broad spectrum organisms implicated, most commonly being the gram-positive bacteria, others being the negative, coagulous negative staph, fungi, indolent cases having epiacnes or nocardia. A large majority of organisms, cases no organisms are detected. Classifications based on the timing can be fulminant, acute, chronic. Entries can be either exogenous or endogenous. Clinical features, it's a clinically toxic eye, symptomatic patient with vitritis, vitreous hemorrhage, vitreous membranes, exudates, poor or absent glow. In developing countries, one needs to have on the radar a fungal endophthalmitis, which can be present when you have something like a dry looking corneal infiltrates, convex hyperpion, thick vitreous exudates, fluff balls in the vitreous cavity, plaque on the PC should raise the suspicion of a fungal etiology. Prevention always better than cure. Povidone, iodine, good incision construction, antibiotics, hygienic practice, rule out possible local factors and control of systemic factors. Investigations will be to again control the systemic causes, aqueous or vitreous fluid taps, better yields always from vitreous samples. Culture positivity in India is approximately 38 to 60%. Treatment be as aggressive as possible and as early as possible in the terms of either intravitreal antibiotics, systemic antibiotics. It's a topic of debate. Although the EVS study demonstrated no statistical significant benefit, there have been studies which showed fourth generation fluoroquinones and ceftazidime to have a benefit effect. Again, the EVS study said they limit the vitrectomy to only a PLI, but nowadays with the safety in vitrectomy and patient demands, one tends to do vitrectomy and VA even better than perception of light. TAS, again a 0.22% incidence with clinical features being within 12 to 48 hours after intraocular surgery, limbus to limbus corneal edema, inflammation limited to the anterior segment, gram stain and culture negativity, clinical improvement following steroid therapy. A very common question and a very common clinical dilemma to differentiate between TAS and infectious end-off, where infectious end-off eyes are more toxic, involving more of the posterior segment and can have a culture positivity. Topical steroid therapy are the mainstay. Check for any residual matter. Symptomatic treatment, prophylaxis, again astringent cleaning and sterilization of instruments. Retinal detachment, approximately 30 to 40% of patients undergoing retinal reattachment surgery have had a previous cataract. More incidents seen in ACIOLs. Risk factors being high myopia or pathological myopia. Lattice degeneration, status of PVD intraoperatively, if there's a PCR, vitreous loss, retained lens fragments, zonular dehiscence, or as we saw the ACIOLs being more common. Post-operative vitreous changes, patients undergoing ND-YAG, pseudophakic RDs are typically more extensive, where breaks or HSTs are located more towards the periphery near the aura. Management, standard RD management. Now this is something the lesser we see, the more it's the best. Expulsive hemorrhage, the most dreaded complication associated with expulsion of the intraocular contents. According to Cantor et al., the percentage was about 0.73% in intraocular and in cataract from 0.03 to 0.81%. So the stages are equally such as a choriocapillary engorgement, then there's a serous effusion, stretching and rupture of the vessels, as you can see in figure C, and then D, the expulsion of the intraocular contents. There can be, due to fragile blood vessels, a sudden intraocular hypotony. Clinical features being the patient complains of severe pain, the surgeon appreciates a stony hard globe, loss of red reflex and forward displacement of intraocular contents, and final the expulsion of the intraocular contents. Prophylactic measures, strict control of the hypertension, adequate anesthesia, gradual lowering of IOP, avoid rapid decompression of the globe. Once it started, intraop, early recognition, tamponade it, reposition of the intraocular contents, intravenous hyperosmotic agents, sedation, lowering of systolic blood pressure, removal of the lid speculum. Post-op, usually wait for 2 weeks to intervene for drainage procedures or pars plana vitrectomy. Of course, if there's a retinal detachment or if the VH is not resolving or if there are retained lenticular matter or if there's an associated vitreoretinal traction. These are my references. Thank you.
Thank you, Dr. Indranil. I think you did a comprehensive job to cover all these. Each topic is, I think, one on its own is a complete topic, right? Thank you.
Thank you, sir.
So I now invite Dr. Ajay Arora to present his talk on intravitreal injections and surgical management of endophthalmitis.
So thanks Sangeet and Anuj, and we at least have a few audience now. We started off with just 3-4 people. Thank you for coming over. I'll be talking on intravitreal injection and surgical management of endophthalmitis. So we would all like patients to be like this and not like a disaster like that. So what I'll be discussing is how do we diagnose early, sample collection, common presentation of and organisms, intravitreal injections, how do we give it, when do we give it, what we inject, and a few challenging cases. So whenever we have a case where we have a reaction which is more than anticipated, we have to differentiate between whether it's sterile or infective. And when you can't, you should err on the side of it being infective and treat it as infective. Now, there are certain things which do help us differentiate. A TAS will usually appear within 24 hours, while an infectious endophthalmitis, unless and until it is a massive Pseudomonas reaction, it usually takes a little time. Then you have a limbal to limbal swelling, which is present in cases of TAS, and you have on a B scan in TAS, which may be anechoic, and there are other features which are important, and of course culture negativity is there. So we have to collect the sample, transport it, do a grams in kVh, and probably do a PCR. So we normally take the sample in a 26 gauge needle with a 2 cc syringe, transport it in an ETO sterilized bag, which usually is sent to the lab as soon as possible, or if it is to be done late in the evening, then we store it at 4 degrees Celsius and send it as soon as possible. Or we have an option of plating it within the operation theatre. So this is what you should have when you want to do it within the operation theatre. These are the media which are there, the 2 slides by which you can make a diagnosis of whether it's gram stain and kVh. And sometimes we do send for a PCR or an exciton, as I'll show you. So why it is important to do a grams in kVh? Because we want to know whether it is gram positive, negative, whether it is a bacillus or a cocci or the gram positive rod. Because in case you have multiple cases coming from some place, we can see what could be the cause for those infections, whether it is a supply chain, when it is gram negative bacillus, when there is a gram positive coccus, then you should suspect the personnel, and it's a gram positive rod, we have to suspect an anaerobic bacillus, you have to suspect a contamination of the apparels by a soil contamination. So we have to also not completely follow EVS, because the organismal distribution within our country is different. We have more of gram negative involvement, which was not there in the EVS study. We also have seen that over the period of time, if you understand the resistance which the antibiotics have developed in India, vancomycin had a resistance of about 4% in 2004, this is about 6% now. Ceftazidime had a resistance of about 8%, and it's almost about 65 to 80% now. So the resistance of ceftazidime has increased, and it is probably not prudent now to use a Vanco-Cefta combination. Usually we have shifted over from Vanco to Tazobact. So this is just to show you which we have been doing. Vanco-Cefta does work, and this is just to show how this patient responded over a period of time. So appropriate timely intervention with an intravitreal antibiotic does really work well. And this is what we used to do, a gram positive, a gram negative, sometimes a combination of antifungals. So we normally would used to inject Vanco and Cefta. It's not important to remember the dilution, it's important to remember the terminal target doses, which is useful. Or we can give a Vanco amikacin, and best now we use a Vanco Tazobact. I normally do not inject dexamethasone initially when I'm not sure if it is fungal, but if we suspect a fungal, we go ahead and inject voriconazole or amphotericin B, usually voriconazole, because it's broad spectrum. And this is what we normally do, a Vanco and a Tazobact combination. There are other agents that are available, as I'll show you in some of the cases, and there are newer antibiotics which are easily available. You should have these charts ready and put up in the operation theatre, which actually helps us in injecting. This is for the anterior segment people that you can actually inject by a device which I have made, and it's easily available. You should use topical anesthesia, 5% povidone iodine. The eye is cleaned with is cleaned with povidone iodine, and you use a 30 gauge needle. Use this device, which we use it for anti-VEGF injections, but as a retina surgeon you may not need this device, but actually helps because you can prevent the egress of fluid from the vitreous cavity. It's a very simple thing. You don't need a caliper, don't need anything to hold the eye, and some patients who keep on moving the eye, this device actually works very well. So these are the various devices. We actually boiled down to 2 devices which we are using now, and basically for vitrectomy you use a perivalve anesthesia. I will not go through the videos because we are short of time. You remove the pupillary membrane, clear the vitreous debris behind the IOL, and put in a 6 mm infusion cannula. And then you go ahead and do a cold vitrectomy. You take a sample for culture. This is the same device I'm using for holding the globe as such. Normally we do not induce a PVD, but if it is already there, you go ahead and remove as much possible vitreous is there, and inject the intraocular antibiotics in the end. So this is an interesting case which actually was shared by Dr. Ashish from Gurgaon. So this patient was a type 2 diabetic, had received intravitreal injection Avastin, and underwent pars plana vitrectomy with Vanco, Tazobacter, and microvalve was negative. 48 hours later, a revitrectomy was done. Vanco amikacin was injected, and patient was sent for a second opinion. Underwent a second vitrectomy. Voriconazole was injected, and vitreous sample was sent for PCR. So when it was sent for PCR, it showed Bacteroides fragilis, which we had to treat with imipenem. Patient responded well. So it's very important to come to an organismal diagnosis if you want to treat these patients. This is another patient who underwent first a post-cataract surgery, Vanco-Tazobact. Actually, the hypopyon increased, underwent vitrectomy with imipenem, and microbiology was negative. A revitrectomy was done, sample was sent for PCR, and that showed Pseudomonas aeruginosa, where we went ahead and gave vancomycin and linezolid. Patient subsequently received colistin, and patient responded well. So this is last case which I want to share with you, that sometimes you have to be persistent to reach an organismal diagnosis. This was a 63-year-old diabetic. This was way back, and I have followed this patient for the last almost 11 years. I've lost a follow-up in 2021. She was a 63-year-old diabetic, underwent phaco. I operated her on 2009, where we did a vitrectomy, gave vancomycin. Then she underwent somewhere else, underwent 2 more vitrectomies, received 14 intraocular antibiotic injections over a period of time, received multiple Avastins for diabetic macular edema, underwent culture and PCR which was negative, vitreous cytology that was negative, PET scan was done, PET CT was done which was negative, and also received intravitreal methotrexate considering it to be an inflammatory disorder. So she came back to us, and it was in 2015. We were not sure what we were dealing with, whether it's a masquerade, so we had to get a sample from somewhere. And I thought the patient had had 3 vitrectomies. Where will I get the sample? Now all the vitreous was actually gone. So went ahead and took a 32 millimeter thoracic 26 gauge needle, bent the cannula over a 50 cc syringe, and said the only place I can get the sample is from the zonular area. Nobody would have done vitrectomy close to the zonule, so I went to the zonular area, picked up the samples, and you will see here when I was aspirating from there, I saw something coming out from here, and I went into the AC, went to the angle, and you can see some yellowish material coming. This was taken, we completed the vitrectomy, and you can see here the various steps being shown, how it was being done, and I sent it to Shankar Nitrale and Exciton. So Shankar Nitrale said it was P. acnes, and Exciton said it is fusarium. So what do? I treat it for both, and the patient fortunately has done well. So basically organismal diagnosis is important. You should try to reach a diagnosis. Where do we know? Don't inject in intravitreal injections. If you have a coexisting retinal detachment or the choroidal detachment, then you should inject, but it should be done by a VR surgeon. If it's a virulent infection, best is to refer to a VR surgeon. If it is a fungal infection, where a vitrectomy may be required. If you have a retained intraocular foreign body, again where a vitrectomy would be required. And if your intravitreal injection has not worked, best is to send to a retina surgeon. and there a core or a near total vitrectomy would be done, or maybe sometimes a radical vitrectomy is done. So these are the current indications for the pars plana vitrectomy. So what the take-home message is, must take all the steps to prevent endophthalmitis from occurring, differentiate TAS from endophthalmitis. When in doubt, err on the side of infection, use intravitreal antibiotics early. If suspecting bacterial, use steroids. If suspecting fungal, you must treat with antifungals and avoid steroids in the beginning. Timely and judicious vitrectomy is very important. Organismal identification is very important. Must use appropriate antibiotics. And what is most important is to talk to the patient, talk to the family. You must tell them the truth that there is an infection. It's a difficult situation. We have to handle it. Anterior segment surgeons particularly should not tell you छोटी सी बात है vitrectomy वाले आप vitrectomy करते हैं आप ठीक हो जाएंगे, but that's not very true. Do not hesitate to take opinion and refer, and remember, save the eye and save yourself. Thank you very much.
Thank you, Dr. Ajay. Anything?
Sir, the final case that you showed, the patient with multiple surgeries and then finally P. acnes and fusarium. The management, sir, would you plan to remove the IOL? And,
so this patient was about 74 years. So she was talking in Punjabi. She said, "Kaka, mera IOL na kadna." When she said that, what do I do? After 3 vitrectomies, I wanted to take out the IOL, and this patient actually I operated in Chandigarh in the beginning. So she said, "Kaka, mera IOL na kadna." And I said, "Mataji, if this will be required, last time I try kar rahe hain. If I hope you understand Punjabi. And after this, if it is not possible, we will have to take out the IOL." It worked, fortunately. I have not, so I followed up till pre-COVID time, but after the COVID time, I've lost contact with her. I hope she's okay, doing okay, but that's what the story is. Yes, personally, yes, I would have removed the IOL. Yeah. And sometimes it's emotional, it's very difficult to, kya kare? Vanco-Tazo. Vanco-Tazo. Yeah.
Now, how do you decide, sir, after a primary vitrectomy, you always aim to go for more than 4 vitrectomy. So how do you decide that after surgery the patient is not improving, that you need to re-inject the patient or go for re-vitrectomy?
So when we have done the vitrectomy and we find the patient, so we look at patient's vision, we look at the clarity of the media, and we hope that we have not created a complication like we have not created a regardi. That's always a possibility if we've been very aggressive. So the patient's media is becoming clearer. I can demonstrate, so whenever I'm operating, I presume that I have a B scan available. So I'll check the vision, I do an indirect, see the media clarity, do a B scan and show to the patient. Not only that I'll show to the patient, ये exudate steps सब clear हो गए हैं. ये exudates बाकी. So I tell them that काम दवाइयों ने करना है. If you have a pus-filled cavity, I remove most of the pus. There is some pus left behind. The medicines are going to work. So it's very important that I may have to re-inject after a vitrectomy in case I don't go ahead and do a second vitrectomy. I may have to re-inject in a vitrectomized eye if required. And by that time, I would have made an organismal diagnosis. I think that's how I personally follow. Anybody else has a different ruchir? Anybody else has a different technique of following these cases? Otherwise, what a lot of people from RP Center have done, they do a radical vitrectomy. They will go ahead and remove the hyaloid, put in silicone oil. I prefer to avoid putting silicone oil in these cases because it's very easy. But if you have a retinal detachment associated with an endophthalmitis, I would definitely go full force, remove the vitreous, try to settle the retina, put in silicone oil. I've had a situation where I was operating and I found that removing the vitreous was difficult. Patient had a detachment. I injected, did a vitrectomy as much as possible, and I took up the case after a week. When I took up the case after a week, the PVD had occurred and I was able to clear the vitreous very well. So there you have to go back and communicate with the patients extremely well. So if it is bacterial, so actually there's a very good study which has come up with at Eluprasad. They take an inflammatory score. If your score is above 10, you must, so they do the scoring system. Inflammation control is an important component of endophthalmitis control. So therefore dexamethasone, and this was proved way back in 1973-74 with, I don't remember the exact paper, but it was done on rabbit eyes, which showed that if you inject dexamethasone, the results of clearing up was much better. Based on the same principle, they have come out with the inflammatory score. So if I'm suspecting bacterial, I would inject dexamethasone. If I'm suspecting fungal, I will try to treat them with antifungal and then.
So one thing is like if you are undergoing vitrectomy in an acute endophthalmitis case, there is no middle way. Either you just do a core vitrectomy and inject, or you do a complete vitrectomy and put in oil. There is no middle way, right? You just do a PVD induction and just remove the vitreous central. The patient will ultimately land up with retinal detachment only later on. So you have to be on one side of the coin.
Thank you.
For the next speaker, we have Dr. Sangeet Mittal. He shall be speaking on managing strategies for retinal hemangioma.
So, good afternoon now. So my talk for today is taming the tumor management strategies in angiomatosis or retinal hemangioma or hemangioblastoma, whatever you call it. These are the sporadic or multiple lesions in the retina associated with von Hippel-Lindau disease. They are orange-red vascular tumors just appearing like strawberries in the retina, and they are associated with dilated feeder vessels. The indications of treatment include vision-threatening complications like macular edema, retinal detachment, vitreous hemorrhage, epiretinal membrane, massive lipid exudation, neovascularization, or amblyopia. And the different modalities which we have now is laser, cryopexy, intravitreal injections, external beam radiotherapy, brachytherapy, transpupillary thermotherapy, photodynamic therapy, or surgery. And I'll just go over some cases in which these hemangiomas were managed differently in all these patients. So this is the first option. This is a peripheral tumor, a single tumor, and there was an exudative retinal detachment associated with it. So we just did a cryopexy to the tumor. We did it in a triple freeze thaw technique, and you see over a period of time the tumor has regressed. The dilator vessels have become the normal, and the patient is still doing well. So just with a single application of cryotherapy in a triple freeze thaw method has helped in this patient. So this is another patient. This is quite an old patient. It was a 52 years female, and she presented with decrease of vision for 1 month, and this was done quite time back in 2004. I had done this case, and she presented with this picture. The left eye, there was a massive mass overlying the optic nerve head, and there was an exudative detachment associated with mass. And at that time, fortunately, we had an access to a treatment which we call photodynamic therapy, and unfortunately nowadays we don't have an access to that. And but this was the first case. There were no previous reports of photodynamic therapy being used in these type of tumors earlier. So this was a B scan. This was confirmed. The tumor was confirmed on FFA, B scan, the Doppler ultrasound, everything. And we did a photodynamic therapy in this patient, and there was slight modifications we did because the flow of this tumor is not exactly what happens in CNVMs or in choroidal hemangiomas, for which there were previous reports being treated by PDT. So we changed the infusion time to 5 minutes instead of 10 minutes, and we initiated the laser 1 minute after completing the infusion, and we increased the duration to 166 seconds. And this is one of the pictures. You see 3 months post PDT, the tumor has regressed in size, the exudates have gone down, the exudative detachment has resolved, And you can see on FFA, this was confirmed again, the tumor has almost gone completely. And same findings were seen in Doppler ultrasound and ultrasound. Again, this was a patient who had presented to me. This was again at that time, there were no previous reports of a patient who was diagnosed to have retinal detachment with PVR, and there were multiple capillary hemangiomas. He was a 28 years male. Sudden decrease of vision, right eye, left eye again was thiatrical because of the complications of these multiple tumors in the other eye also. There was no significant systemic and family history, and this patient came to me with the rhegmatogenous detachment. The break was right next to the tumor, and there were no previous reports at that time. It was and the patient was one-eyed, so I thought, like, why not go ahead and try to do something rather than leaving it like that. I advised the patient with retinal surgery, but he was not ready for it. And however, he came a week later with again a further drop in vision and a severe PVR. And at that time, he was ready for surgery. Went ahead with the surgery. This was, I think, in 2007. And so you can see the multiple tumors. So first of all, we took care of the PVR. We removed all the membranes. And then we excised, we did a cautery, we used a heavy cautery around the tumor, and then we excised the tumors one by one. All these tumors were taken out. So at that time I was not aware whether we can just go ahead and eat up the tumor inside the vitreous cavity or not. I was very afraid, and one by one we just excised the tumors and then took out these tumors out of the eye. And after excising all the tumors, the patient was multiple large breaks with retinal detachment, which can be easily managed afterwards. And this is the patient improved to 20/200 over the period of time. We were able to remove the silicone oil in this patient, and the patient is still ambulatory and doing well. This is another case, 29 years female, sudden decrease of vision with 1 week, and again multiple angiomas with exudative RD. And in this case, the tumors were not very large. And one thing I'd like to say is not only there is an exudative detachment, but there is a lot of traction over these tumors. And you have to manage that traction also. If you just plan to give steroids and give intravitreal steroids or something, they are not going to work much because there is associated traction also. So in this patient, again, we planned to do a vitrectomy. We did a vitrectomy, we took care of all these membranes which were there. There was there were multiple layers of vitreous. There was a lot of vitreous cases. So you have to take care, all these membranes are removed. And in this case, because the tumors were very small in size and there was no breaks, we did not want to convert exudative or a tractional retinal detachment into a rect detachment. We planned just to isolate these tumors and do a diathermy over these tumors. And one by one, these membranes were removed. And you see the multiple membranes. I've already peeled membranes over there, but again there was a membrane. So once these tumors were isolated, we just do diathermy over these tumors one by one, and then I just used air as a tamponade in this patient. And this is, I think, 3 months later, and you see the retina has settled now. The smaller tumors have totally disappeared from the eye. So the big one tumor is there, but there is no traction over that tumor, and it's not causing any problem till now. So I've left it like that. So this is a patient, I can say it's a pseudo-cavernous hemangioma of the retina. There were multiple tumors in a small complex over there, and there was an epiretinal membrane, which was the indication of surgery in this eye. And again, we went ahead with surgery. We removed the epiretinal membrane. The PVD was induced and epiretinal membranes were removed. And you see again this membrane, once I tried to peel it, it was impossible because there was oozing of blood once I tried to peel it. So again we did a diathermy around the whole complex. And this is a totally unedited part, the excision of this tumor. And just with your cutter you can just go ahead and now you can just excise the tumor inside. I have not seen any excessive bleeding when you are cutting this tumor with your cutter itself. Just see, this is the totally unedited. Just I think it's multiplied by 2.5 times for the sake of time. Otherwise, it is. So again, the whole of this tumor was removed. Whole of this complex was removed. There were multiple tumors, and I don't know. There was a post-op picture also. So, I'm sorry, there is no post-op picture, but the patient did well again, and he is again a good post-op visual recovery. And this is the last case, retinal hemangioblastoma. And this was the exophytic type of tumor which was going towards the choroid. Again, 35 years, female, 6/36 vision. She had multiple sittings of laser and cryo for 2 years, past 2 years, and multiple injections of Ozurdex had already also been given earlier. So this is pre-operative condition. There was a large tumor in the inferior temporal quadrant, and there was associated macular edema. And again, in this patient, we started, we thought we'll do the diathermy and we'll just excise the tumor inside the eye. But the problem in this case was that the tumor was very adherent to the underlying choroid because it was an exophytic type of hemangioblastoma. And you see, once I started excising this tumor, the tumor was very high adherent to the choroid. So in this patient, we planned to do chorioretinectomy instead of only a retinectomy. And we went ahead, we did a chorioretinectomy, and the tumor and the underlying choroid was totally excised from this eye. You have to take care that your diathermy should be very high, and because then only there will be no bleeding, or there is a very small risk of venous embolism after such a large chorioretinectomy in the periphery. So if your diathermy is quite good, these risks decrease. This is 6 weeks post-operative. The patient regained a vision of 6/12, and the patient is still doing well after some time. Now it is 2 years post-operative. So last case, I think this is intravitreal injection. We had used Eylea for this case. This is again a patient who had this is a one-eyed patient. The patient has not agreed for the surgery or any other treatment, active treatment. So this patient comes with metamorphopsia, and this is the patient. I went in and went ahead with Eylea injection for this tumor, and this is 1 week post Eylea injection. The edema has gone down, the patient's symptoms have improved, and the patient has undergone 7 injections of Eylea in the last 1.5 years, but still the patient is doing well, maintaining a 6/6 vision, and is not agreeing for any other treatment rather than this. Thank you.
Amazing, Sangeet. So just coming to my question through your last case, when would you like to operate the last case which is doing well on Eylea?
I won't operate if he is maintaining a 6/6 vision just by Eylea, if the patient affords the treatment and is very happy with it.
So your indication is if there is a complication because of angiomatosis, you will go ahead, which means either a persistent
exudative or retinal detachment, then though it becomes must that you have to operate.
But fantastic, it requires a big jigra to do it.
Thank you so much, sir.
One question, sir. Sir, like in one of the videos, you had not removed the tumor, whereas in the other ones you have removed it. So when do you take a call, sir, as to remove or let it be? Because when we remove, it's like a massive break there.
Yeah. In that case, again, the patient had exudative and tractional retinal detachment only. That case was done quite a few years ago. So I thought like I'll just, these were very small tumors and there were multiple. So if I had to remove them, I had to create multiple breaks and convert exudative or tractional detachment into a pure rect detachment, which would have been very difficult to manage. So in those cases, that's why I just thought I'll just do diathermy and let the things remain. I have already removed the traction over the tumors, which was causing the problem, and again the patient did very well. So if you have a reg RD, then though there is no other option, you have to remove the tumor. There's solitary large tumors, again I think only the diathermy does not work well, because the one tumor that was very large in that second case, it did not settle down. It still persisted, though there was no traction over it. In that case, you have to remove the tumor. No, I have not used actually. I can't say on that. But most of these cases, they are generally flat in the periphery, these localized detachments. And yeah, that was the first case that I did. And I didn't know whether it will behave well or not. I think I used an encircling band in that case. That patient? That was done in 2007. 16 years. Yeah, he's doing well, no recurrences.
Thank you so much, sir. I now invite Dr. Saurabh Luthra, sir. He shall be speaking on third eye and third hand in macular hole surgery.
Good afternoon, and it's not afternoon as yet, but I am in fast forward mode because we have to just give the hall away for the next session. Dr. Ruchir is here? Yeah, I see you. Yeah. So after those daredevil surgeries, I'm going to show you simpler stuff so you don't have to worry. Yeah, so the 59-year-old female with 660 vision in the right eye, 6'9" in the left. And this is the Optos ultra-wide field image with showing a macular hole. And this is the pre-op, macular hole parameters, quite a big hole there. And this is just, a video of the surgery. And you can see it's a very big hole. So just do an ILM peel, VBG assisted cabbage leaf technique as proposed by Dr. Ajora sir, and then trim the flaps so that there's no redundancy of the flaps. But this is the second surgery. Actually the first surgery failed, so now what I've started doing is that I inject a bubble of PFCL over the hole, and the flaps are just kind of pushed back over the hole under PFCL, and the PFCL is removed at the end. So that way, it's very, you make sure that the flaps stay put, because I tried a lot of things, even viscoelastic, but it doesn't work as well as this technique. So this is the post-op, and you can see that the hole is nicely closed. Vision improved to 624. Another case, 50-year-old male with diminution of vision in the right eye post blunt trauma, 360 in the right eye, 66 in the left. And this is the pre-op image, and again you can see a fairly large macular hole there. And the primary surgery, you can see that these are the pre and post primary surgery images. 4 weeks post primary surgery, you can see that the hole has not closed. So again, I'll show you the video. The same technique, and the PFCL comes in handy here. And with the intraoposity, you can actually, after putting PFCL and pushing back the flaps over the hole, you can see intraop that the flaps are staying put, and the hole is covered. So again, under PFCL, so I use this finesse loop, which is quite atraumatic. I find it, and very easy to push, because otherwise if you use a forceps, sometimes it gets caught in the forceps, and you just remove the flap with your forceps. There's a flap loss. But here again, under intraoposity, I can see that after I pushed it towards the hole, the flaps they remain put under PFCL, and then I remove it in the end. And this is the 4 weeks post flap repositioning, and the hole is nicely closed with a vision of 618. So this the PFCL assisted inverted ILM flap technique can be used as a primary approach for large and chronic macular holes, for recurrent macular holes, and PFCL acts as an efficient third hand, and intraoposity as a very useful third eye adjunct in achieving successful outcome. Thanks. I'm being forced to do that because I have a program to finish. Yeah, his presentations always produce tachycardia. The flap will not stick. Yeah, but I found with the finesse, it's very gentle. I mean, you just stroke the flap towards the hole, and that's all. You don't have to stuff So with the forceps, sometimes you have that apprehension that you might touch somewhere, and in fact we all have had, especially in our earlier cases, bleeds at the edges of the hole. Sometimes when you're tucking it in or you're trying to oppose it, the forceps can cause the back. With a closed forceps you can, I've done that also, but I've realized that this is virtually atraumatic. It works very well in my hand, the finesse.
Because there's always a risk, because there is no ILM over the retina. With the finesse loop, there's always a risk that your finesse loop is going to directly touch the retina,
So,
which is bare of ILM.
correct. So what I do is that I generally try to remain over the flap. So instead of stroking it from the edge, I stroke over the flap and try to use always stay on the surface of the flap rather than on the NFL, on the nerve fiber layer. So that way try to be least traumatic.
So one thing that I started doing in the last few years is at the end of air fluid exchange, under high magnification lens, I just use the forceps to reposition the flap. So because there's a small fluid left just over the macular hole, we don't need to go very close to the flaps, and it works well. So, and it can only be done with the macular lens of the reset. You can't do it under wide angle, but it works really well. So you can actually avoid using PFCL with that.
Yes. So I used to do that, but with that residual layer of fluid that you tell, sometimes the flaps again they unfurl. You'll realize that by the time you're taking out your the cannulas, it has a tendency to unfurl. But with this I've realized somehow under PFCL they just stay put. I don't know. It's working well in my hands. Yeah. So I've reached here after going through all those stages and trying all those things. Yeah.
Right.
Thank you. Next.
Hello. So thank you so much, sir. So now Dr. Ruchir will be talking about complex diabetic vitrectomy. Is small gauge the answer? First of all, I'd like to thank Dr. Sangeet and Dr. Anuj and UKSOS for giving me this opportunity. Actually, most of the talk has already been covered by Dr. Vishali very well. She's already talked about 27 gauge surgery in diabetic vitrectomies. So, there's no financial interest involved. So, what are the challenges with diabetic vitrectomy? First and foremost is the difficulty in finding and managing the plane of dissection, and specifically if the membrane is very close to the retina attached and the multifocal attachment, it becomes difficult. Second is intra-op bleeding that happens in most of our cases. No matter what we do, there is very high chance of iatrogenic breaks if we are not very careful with the dissection. And one of the underlying reasons is the unhealthy retina that is there below the membrane complex. So bimanual surgery is actually proposed as one of the answers. Most of us do it, although it requires an extra port to be made. It requires extra equipment in the form of a chandelier. It requires multiple instruments. We need forceps, we need scissors, we need picks, we need spatulas. Everything is used. And whatever said and done, personally, I have never felt as comfortable with bimanual because of the problems with illumination. Unless you have an assistant holding the chandelier along all the time, you will never get the same level of illumination that you can get with an endo illuminator in your own hands. So, how has vitrectomy evolved? We've evolved from 20 gauge to 23, 25, 27. So, what change was the size of the width of the cutter, and along with it was the size of the port. So between 25 and 27, what initially we realized was that there was a problem with the fluidics, simply because the size of the port kept on getting smaller without any changes in the fluidics. However, with the introduction of the beveled cutter, now this is with the Eyecon constellation system, but with the introduction of this beveled cutter, the size of the port is now larger and it is more close to the edge of the cutter. So what that has changed is the fluidics of the entire system. So this is just a representation of how the transverse traction behaves, that if you have a wider instrument going between the membrane and the retinal surface, the transverse traction is more compared to when the width of the instrument is less. So I'll show two small surgical videos. The first is a young diabetic patient. Now to initiate, I need to create a plane. For this I'm using forceps. But once I'm done creating a plane, then this is when we start doing sort of a linear dissection where the cutter is at 90 degrees to the retinal surface.
and as you can see, there is very minimal traction being given on the retinal surface. Second is a circumferential form of dissection around the point of attachments, wherein the cutter is going behind the point of attachment along the plane, and there is no bleeding whatsoever happening. So by doing such small maneuvers, we can decrease the chances of intra-op bleeding. Again, as ma'am has already pointed out, we can change the direction of the cutter wherever we want. We can point it towards the membrane, or we can point it away from it. And again, this is cutting the membranes and then going circumferentially around the point of contact. So this is something that I tried with a 25 gauge cutter, but I just couldn't do it because of the width of the cutter and the lateral traction that it used to cause. The next step would be to peel and cut. So in this situation, the cutter is actually behaving like a pick, where a small amount of retina is being elevated, and then the cutting is happening. So again, in this situation where the visualization is not there, I am pretty sure that the plane of dissection is where I have reached, and I will not be engaging the retina at all. And it is very, very easy to cut the points of contact. And again, once all the points of contact are gone, the cutter can simply be used to clear the bleed that is there, and then to lift the membrane and then clear all the residual vitreous. But then again, this is a case where the retina is attached. How do we, so can we do the same things when the retina is detached? Actually we can, and so the next patient is a one-eyed patient with a tractional detachment. This patient was lasered and then left like this. So when he came to me, he had a circumferential traction. The central retina is completely detached, and the retina is extremely thinned out below that. So once again, forceps were initially used to create a plane of dissection, and after that, as you can see, the 27 gauge cutter actually goes very easily below the membranes. And if we do it gently enough, there is no lateral traction on the surface of the retina below. So most of the complications of iatrogenic breaks are avoided in such cases. Now the same is being used as a spatula to do a blunt dissection of the membrane from the underlying retinal surface. So again, a circumferential dissection around the point of contact is being done, and finally the membrane will be taken out, and a gentle segmentation can also be done with minimal traction over the underlying retinal surface. So what I have come to realize is that with the 27 gauge system, I can go very close to the retinal surface doing a linear sort of dissection. A blunt dissection can be done with minimal transverse traction, circumferential dissection around the point of attachments, and a single instrument is being used for multiple purposes. And my dependence on bimanual surgery has decreased significantly because of the newer systems. Thank you.
Thank you so much, Dr. Ruchir. I think with that we come to the end of this session.
Any chandeliers at all to get a better video for the presentation?
I would try it again, sir, but I think less number of ports is better for diabetics.
No, I'm just saying, a lot of us use chandelier because we want to get a better illumination plus the bimanual thing. So one point which I've been doing and which works well is without using the bimanual, that wherever I get stuck with those things, I use a bent 26 gauge long needle because it has got side cutting. Right. So I can cut all those things when the membrane is free. I go in with the cutter and 25 it works.
I think we should not devilize the bimanual technique. It's very handy in some of these cases, and everybody should know how to do it, one thing. And another thing, I saw your video, you're mostly doing the inside-outside dissection.
Yes.
So what you can also do is, like what I generally do is I start at the optic nerve head. Right. Then I create a wedge between the inner retina and the outer, sorry, not the inner, the posterior retina and the anterior retina. and then you take the membranes from all the sides, the ones you showed in the circumferential manner. Then the dissection becomes very easy then.
So actually truncation had already been done. I did not show that in the video. I had initially done a good truncation and then from inside out.
Right. Yes.
Yes, always I do truncation first to get both the edges of the membranes.
Yeah.
Thank you.
So thank you, and I think let us all have a combined photograph, because all those people who remain behind should get the credit for it.
बढ़िया है, ये तो बेस्ट है, इससे अच्छा कुछ हो नहीं सकता। हाँ मैं लगाता हूँ, I'll just put it on.
आगे से ना ये वाला जो सेशन है ना वो डिसाइड हो रहा है कि उसे जो डिसाइड करके ना पहले जज
पहले ही कर देंगे सर। हाँ
जज करा के एंड वी डिक्लेयर
लगा दिया
सभी गए भी अब लेट्स स्टार्ट कोई बात नहीं, लेट्स थ्री ऑफ और क्या करें क्या मैं सामने उधर लंच एरिया में देख के आऊं नहीं यू कैन नहीं
So shall I start? Okay. So very good afternoon. Today I'll be talking about the few of my achievements and publications which I got in Young Achievers Award. As of now, I always believe in following few mantras in life. So life has two rules. One, you should never quit, and you should always remember this first rule. Comfort is always the enemy of achievement. So in order to achieve anything in life, you should never be comfortable. And yes, always have a I can do it attitude. So if you follow all these mantras, I think you can achieve anything very easily. So a few of my contributions that I made in the year 2022-23, coming on to the publications. So I had a case which I got published in the Curious Journal in the month of July. It was on multimodal imaging in a case of chronic sympathetic ophthalmitis. So what was the catch here was that in all the literature, there was no publication ever of chronic findings of sympathetic ophthalmitis of ICGA. So which we caught, and we found out that yes, it is totally matching and we should publish it. So then it got published because of that. Another publication was done in the month of October, and this was pediatric lupus retinopathy, which is a rare manifestation of a very grave disorder. So this was a child who wasn't aware that she had lupus, and we just saw her retina, and then afterwards she was diagnosed and treated, and she totally recovered within few months. This is under peer review, again in the same journal, and this is a case of central retinal artery occlusion with a triple cilio-retinal artery sparing. So which is again a very rare finding in like roughly 5% or 10% of cases of all, that you see 3 cilio-retinal arteries spared. And recently in this October month only, we sent another publication for a surgical technique in Indian Journal of Ophthalmology. So this is a code to crack nucleus where we have utilized physics and we have discussed it with professors of physics and try to create an innovation as how we can make this nucleotomy a very simpler and an easier way. Not just focus on lateral separation, rather we need to make it go deeper. So using vector analysis and everything, so we have just send it for publication. When it's get published, then yes, we'll talk more on it. So a few of my presentations in last year AIOC conference, I had an instruction course which was human analog to artificial intelligence for eradicating the challenge of diabetic blindness and Indian experience. So we have been conducting this IC for past 4 years, and we are educating people that if a machine can do that, and if we all get educated and we can easily catch all the basic findings of diabetic retinopathy. So you don't need machines to do that. Even you can do that. So the issue comes that we don't just focus on it and we are all dependent on machinery. So in UKSOS meet last year, I had a free paper presentation on a case of choroidal osteoma, an e-poster on sympathetic ophthalmitis, had a surgical video on 27 gauge macular surgery, and I took active participation in live surgery session which was held at Drishtiya Institute. In the AIOS conference held in 2023 May at Kochi, again I had an instruction course. So this was human analog to artificial intelligence extended. It was conceptualized by Dr. Malay Chaturvedi, and I was the content curator in that instruction course. Apart from the e-posters, paper and video presentations, I was also the faculty at diagnostic skill transfer course where I taught OCT. After this, I was invited for a guest faculty lecture in the UP State Zonal Meet held at SGPGI Lucknow, where I got the opportunity to interact with residents and taught them some basic skills. After that, there was another guest faculty. I was invited there at Rama Medical College, Kanpur. It was held in the month of September. And again, I interacted with most of the residents there, and it was a very good experience. This year, I had a lecture on OCT basics and clinical applications, and I'm here applying for my candidature in this Young Achievers Award session. So to sum up, that success is sum of all the small efforts which are repeated day in and day out, and one should never stop hustling. So good things happen to those who hustle. Thank you so much for your patient listening.
Thank you for your presentation. I want to know what is your line of management in CRO. I found that it is very, very difficult to get back the vision in CRO. What is your experience?
Yes, sir, definitely. So we counsel all the patients that whatever we are doing now is just to salvage what is there. The purpose of treatment is not to improve your visual acuity, but the main focus changes to the systemic part. That is more important. Sir, जिंदगी रहेगी तभी तो कुछ करेंगे. आँख का क्या है सर?
That I want to know. What is your success rate? How you?
First and foremost, if ever we catch any sort of occlusion, be it arterial or venous occlusion, we definitely have to send the patient for a neurologist or cardiologist workup. That is of utmost importance. And sir, as soon as those parameters start getting, better.
You don't get much time for evaluation because
No.
So I think you only have to manage the cardiac and physician part also.
Not per se, sir. Actually, patients
Are you giving oxygen like something?
No, I am not doing that. I am personally not doing that. I do give them ocular massages and all, but I don't do a cardiology workup at my place.
What is your success rate? I want to know because it is very difficult to get back vision in CRO.
So again, my point is that visual acuity is not important, sir. Because as such, I personally counsel all the patients that visual acuity is not the part for which you are here. It is your systemic part.
As an ophthalmologist, for our first priority is to get back vision.
You won't, sir. You won't be able to ever. Because retina is a neurosensory part. So once damaged, it remains damaged. Even if edema goes down, it won't ever be normal. Rather, in chronic phases, the entire retina goes thinned out and gets atrophic. So you will never have 6/6 vision. You can do anything, any sort of treatment, you will never have that. So I do tell the patients, I show them that, yeah, this is the OCT right now, and after everything goes fine, it becomes this. So yes, there are some issues which you will face. So I do counsel them about that. But yes, systemic part is really important to handle.
Yeah, that is for further management.
Definitely, sir. Definitely, sir.
And what about artificial intelligence in early diabetic retinopathy?
Yes,
how early you are able to diagnose it?
Yes. So what was our IC? IC was not focused on artificial intelligence. Rather, we was educating people that we used to conduct live voting also. That we used to teach them that these are few features of diabetic retinopathy. And if I teach you that, you can also catch that this is a vision threatening diabetic retinopathy or not. You don't need artificial intelligence for that. Because in the state of our country, in rural areas, it is very difficult to get access of artificial intelligence. So if we educate general ophthalmologists also, they can very easily catch those features and send the patient for referral.
No, just I want to know, do we get any fundus photograph? Because whatever we are getting early retinopathy, diabetic retinopathy changes, before that artificial intelligence helps us?
No, sir. So here I would like to point out that artificial intelligence, maybe they have started using more than moderate criteria. Okay. So what they do is they classify the things, one is less than moderate and one is more than moderate. So sir, if they catch few features, they'll say that this is less than moderate and it gets over there. They don't send the patient for referral. But if there are certain features which the machine captures, and if they see it, they'll straight away label it as more than moderate, and then the patient is sent for referral. So our point was, if the machine can do that, why not us people, we can also do that. And it's very easy, because fundus cameras are very good these days, and the central imaging is done very easily. Cataract ho ya na ho, sir, that doesn't matter. Still you can get a good enough image and we can do the referrals ourselves. So from the last 4 to 5 years, we have been doing this instruction course, and it was very successful. We used to conduct live voting, and the success rate before instructing them went from 60% to 90% straight away. People were actually used to, capture and send and identify the vision threatening features.
Yeah. Thank you. Thank you.
Thank you, sir.
Sorry, I missed your presentation. I just want to ask you about that. I think it was on CRAO, right?
CR, triple cilio-retinal artery sparing CRO.
Sparing CRO. So, like we used to do massage and paracentesis and all those
yes,
things.
ma'am.
I just want to ask you, like, how is it in what cases of CRO it is helpful?
So where, ma'am, we used to see the plaque present there only we do a massage.
So in occlusive cases,
Yeah,
it doesn't
yeah.
work at all. So that
Yes,
is why
ma'am, yes,
most
ma'am.
of the cases are probably occlusive. That is why we don't get gain in vision and all.
So firstly, we need to identify that if there is a plaque or not. So if we see a plaque, yes, why not? We definitely go for a massage.
Yeah, and the second thing about artificial intelligence, probably it is in a developing phase.
Yes,
so
ma'am.
Till like in this era, we are not able to diagnose accurately. But I would say the doctor-patient ratio is too high in India. So you cannot see all the patients.
Yes,
so probably
yes,
in future, artificial intelligence would be the way to for the referrals and all, especially in the hilly areas like Uttarakhand.
The issue comes with the economics, ma'am. With the logistics also. So in rural areas, it is very difficult to get the access of artificial intelligence.
No, it's not the access. Actually, you just have to take a fundus photo and you have to send to the main center.
Yeah, and then
probably there
you have
they
to
will screen
upload it on the software for that.
Yeah.
So my point is that why do you need to do that if you send our residents or fellows even?
So there are certain places in Uttarakhand where the access is very difficult for the patients to come down.
Yes.
So probably if you train one of the person to just take a picture,
take a picture and send it.
That would be of great help.
Yes.
That is the basic motive behind this thing.
Definitely.
What is your experience regarding chronic sympathetic ophthalmitis?
Sir, it was a very good experience. So during my fellowship, I saw this case. And
how many cases you are getting in perforating injuries or any other?
So this patient underwent a vitreoretinal surgery for endophthalmitis in other eye, and it eventually became thicical. So when we saw the patient, she had a very dense cataract, and I couldn't see all the features by just looking at the retina. But when we conducted a multimodal imaging, I saw characteristic features on OCT, FFA and ICGA. So the features which we picked on ICGA, they were never mentioned in any of the publications ever for a case of chronic sympathetic. They were mentioned for acute, but never for chronic. But the point which we looked out for, that if we give a prompt treatment and prompt identification, she got improved, sir, within 4 to 5 months. So during my fellowship only, she recovered everything.
How many cases you have experienced chronic sympathetic?
Sir, 2 only. Only 2.
Only 2?
Only 2, sir.
So one you told, other one?
So other one I saw, but I didn't treat the patient because the patient was not compliant. So I couldn't treat the patient, but yes, I thought that this is a very rare finding, and I don't think so it's very common to encounter such cases. But yes, I was very happy that she recovered all her vision because of prompt referral and treatment.
Any other research work going on artificial intelligence?
Not on artificial
other
intelligence.
than diabetic retinopathy?
Not on that, sir, but we just sent a paper for a surgical technique in IGO. So that is a very innovative thing, sir, which we are working on. So it is code to crack nucleus, where we are using vector analysis. And generally what we do is that in mature cataracts, we do lateral separation, right? So it gives a lot of stress on the zonules. So what we are doing now is not only doing just lateral separation, you slightly pronate your probe. So what that does, apart from giving this, it sends the crack deeper. Because a vector has 2 planes. And this plane, the obtuse plane, it always works in the Z plane. So if you do lateral separation and add a slight pronation, your crack will go deeper, and this reduces markedly the tension on zonules. So till now we have worked it on like 100 cases and it works. but it will work only in mature cataracts.
You have designed any special chopper for this?
Sir, not a special chopper, but yes, I have mentioned in this paper a Chaturvedi chopstick grip, where we, like if we hold a pen like this, so I'll not hold it like this, I'll change my grip from here to here. So what this does, this will give you this axis also and this axis also. And this will help you in pronation also. So once this publication is over, I'm going to work on that also and definitely get it published too.
Very nice work.
Thank you,
And what
sir.
is your experience on pediatric lupus?
So pediatric lupus again is a very, grave disorder. And in that case, I was very happy that we just saw the retina of the girl. She was a very small girl, sir. And couldn't decipher that what's happening with her. But then I saw her face and there was some sort of malar rash going on. So I started suspecting that yes, this could go towards lupus. And once we got her systemically worked up, it turned out to be lupus. And these days, since we have very good access of rheumatologists and all, so we teamed up with them and we worked with her. And within a period of 6 months, everything returned to normal for her. Though she's on treatment currently also for lupus, but yes, we were able to save her visual acuity and we were able to identify that systemic disorder. Her age was 13 years old. She just came to us with visual acuity loss and we could identify lupus from that. So I think it's a very big deal. But yes, we need to stay aware of our surroundings and the entire systemic area, not just focused on the eyes only.
How you are managing lupus in dry eye in these cases? That is, I think, a big challenge.
Big challenge, sir. It's a very big challenge. And these days, armamentarium has so many lubricants that even we get confused at what to use.
In spite of using many lubricants, we are not able to get the complete results because it is very big challenging.
That's a very tough challenge to complete. But yes, I tend to counsel everyone that no matter what, just put it at least thrice a day, because patients are very poorly compliant regarding putting drops in eyes. So they say कि sir ये तो दवा आप कहते रहते हैं और हम डालते रहते हैं but कुछ हो नहीं रहा है. So I still say that don't let it happen, but you please continue to put drops. So what helps is that it doesn't get worsened. At least it remains stable, sir.
Are you using cyclosporine for that?
Yes, sir. Sometimes, not always. Sometimes. But
because it is autoimmune, I think we should use.
Sir. So results are very good with cyclosporin. I have used them. I have even used tacrolimus also, sir, in few cases. But generally I prefer 1% sodium hyaluronate and it works very well.
What is your experience about tacrolimus? Using at night?
Yes, sir. At night only.
How long?
So I used it for like 4 weeks, 4 to 5 weeks, sir. And
it works well?
Yes, it works very well. Used in couple of cases and it works well, sir.
Okay, thank you. Thank you, Dr. Abhijit. Abhijat, sorry.
Yes, sir.
For nice, very, very nice presentation.
Pleasure, sir, pleasure.
Yeah. Actually, you are presenting the whole session. Yeah.
So ma'am, आपका तो मैं student हूँ जॉली ग्रांट का.
You are getting blessed. Thank you again, Dr. Abhijat. Very, very nice. And you are doing, we hope that you do miracles in artificial intelligence. And this diabetic blindness, I think it is all over world, is a very, very big challenge.
Big challenge, sir.
So I heard just that with artificial intelligence, you are able to diagnose that you are going to get heart attack earlier, 6 months earlier, that you will get heart attack after 6 months. So is anything in diabetic blindness?
So it has its
we are
pros
able to
and
find
cons,
out.
Sir. Yes, it has its pros and cons, and I think if you find it out that in 6 months you're going to get a heart attack, that stresses out.
Thank you, Dr.
Thank you,
Vida.
sir. Thank you so
Again. It was nice, wonderful. Thank you, ma'am.
बढ़िया मजा आ गया इधर बता बफर भी डन है